distinguished panelists and all the audiences who have joined on a Sunday morning. This is going to be a very enlightening session, and I am very happy to be associated. I myself and Microlabs is very happy to be associated with this important webinar on COVID and post-COVID complications, the need of the hour topic. Without taking much time, I would like to hand over the podium to Dr. Mrs. Harsha Annie to proceed with. Yeah, good morning. Thank you.
Good morning. A very warm good morning to all of you. Hope all of you are in good health. I believe I'm audible. So as we all know, ever since the beginning of the COVID pandemic, we have witnessed or come across various or variable and diverse manifestations of COVID-19. And now that we know that the second wave has hit us, we have a huge volume of patients as well. And hence we are at need of understanding the clinical scenario and the complications in a detailed way. On the other hand, if we look at how we are faring in terms of post-COVID recovery, we are unearthing newer patterns which would demonstrate a longer-standing organ damage, since, as we all know, the virus is leaving a deadlier trail post-infection. So I would like to say that this is proving that recovery from the infection is just not the end of the battle. Therefore, a lot of attention is shifting to the post-COVID care as well in today's scenario. Today, we are fortunate to have a very respected and renowned panelist of speakers here who are proficient in this field and have managed ample number of COVID cases. And we also have our eminent chairperson, 5 of them, who would be the experts in this field and would be happy to share their expertise with us. So with utmost pleasure, I would like to extend a very hearty welcome to all our respected chairpersons and speakers to this COVID webinar titled COVID and Post-COVID Complications on behalf of the organizing team, that is the Association of Physicians of India Kerala Chapter, the Central Travancore Physicians Club, and the Department of General Medicine, Pushpagiri Medical College, Tiruvalla, Kerala. I would like to extend a very hearty welcome to all of you to this academic gathering. I'm very sure that by the end of this webinar, we will all be very informed and acquainted with the current COVID scenario. To explain a little bit about our webinar, we'll have 5 sessions, with each of the sessions lasting for about 40 minutes, at the end of which we'll have a 10-minute discussion.
Not audible.
Yeah, internet issue.
Okay, Manjula madam, you can proceed.
Yeah,
madam.
I'll just start. Thank you very much. Good morning to everyone, and it gives me immense pleasure.
You can send your queries and your doubts to the question answer box or the chat box addressed to me during.
Ma'am, can I go ahead, ma'am? Sir, can I go ahead, sir?
Sir, Sunil sir, you are muted, sir.
Sunil. Madam, you can go ahead. Go ahead,
Yeah.
madam.
Good morning and a warm welcome to you on behalf of Microknowledge Academy and the Microlabs. So very quickly, I brief you about Microlabs. Microlab is a multifaceted healthcare organization. It has a state-of-art manufacturing facility and R&D at par with international standards. We manufacture both formulation as well as API, and we market it both in India across the globe. It is one of the transnational healthcare organizations. Our presence is there more than 45 countries, including USA, UK, Russia, and several other countries. I would like to inform you that all our facilities have been approved by the following regulatory authorities, such as US FDA, UK MHRA, Health Canada, WHO, TGA Australia, MedSafe New Zealand, and Ministry of Health of many countries of emerging markets. And we have been recipient of several awards, and regularly we are receiving the award for quality excellence, and Indian Drug Manufacturer Awards also we get regularly, and the recent one being Economic Times Golden Award. And I thank Dr. Sunil Matthew sir and the entire team for giving us this opportunity. We do this activity under Micro Knowledge Academy. Over to you, Dr. Sunil Matthew sir. Thank you very much.
Yes, good morning to all.
Hello, sir.
Welcome to the national webinar of the post-COVID complications. As you all often know, that the webinar is organized by the Association of Physicians of India, Central Travancore Physicians, and Department of Medicine, Pushpagiri Medical College. As you all know, that the second wave of the COVID-19 is coming down. Jagumar, please unmute your mic. The second wave of the COVID-19 is coming down, but we are seeing a lot of cases with immediate and late complications of COVID. This scientific session is actually meant for updating the pathogenesis, prevention, and treatment of post-COVID complications. We are fortunate to get the best faculty in the national level. We had two webinars earlier, that is in the first wave and the second wave at the national level, and which are well appreciated, and the programs can be viewed in the YouTube. Dr. Harsha, the organizing secretary, has taken a lot of efforts in arranging the webinar, and the platform is arranged by the Microlabs. We are extremely grateful to Micropharma entire team, especially to Dr. Manchula and Unni for their untiring efforts to make this program a successful one. With these words, let me conclude and wish you all an enjoyable time.
Thank you, Sunil, sir. Sorry for the technical glitch which happened in between. Sir, I would like to now welcome Dr. Harish Kumar, sir, to the webinar platform. He's the secretary of the API Kerala chapter. He's a focused leader and an accomplished educator with immense knowledge in the field of medicine. He's currently working as consultant physician at PALA. Sir, with all respect, I invite you to deliver a felicitation address to the gathering, sir. Over to you.
Good morning, teachers, great physicians, and my dear friends. We have, as I have witnessed both the other previous programs conducted by the Pushpagiri Medical College on COVID. So we have now the webinar, national webinar on COVID and post-COVID complications. And Department of Medicine at Pushpagiri Medical College and Central Travancore Physicians Club are in the forefront in conducting very nice academic activities. And I also want to mention, in all our API quarterly meetings, we have excellent free paper presentations and poster presentations from the postgraduates of Pushpagiri Medical College. I especially thank Dr. Abdul Qadir sir and all the faculty for allowing the PGs for conducting such programs. And also recently we have the API South Zone and ICP teaching masterclass, and we have postgraduate students presenting papers, and also we have good faculty and also the postgraduates presenting the, and I think it's a great thing for all the postgraduates all over India. So I congratulate Dr. Sunil Matthew, Dr. Harsha Annie Matthew, and the entire team for arranging such a very pioneers in the field of medicine from CMC, Vellore, Trivandrum Medical College, and so on. And also the Microlabs for arranging this platform. And for our postgraduate teaching also, Microlab is arranging our platform. And thanks Mr. Unni, Suhas, and Praveen Singh, everyone for this program. I wish all the very success on behalf of API Kerala chapter, and my own behalf. I congratulate the whole team for an excellent program which we'll be witnessing now.
Thank you, sir. Thank you. Before we move on to the first session, I would like to welcome our chairperson for the first session, Dr. Aravind R. Sir, HOD, Infectious Diseases, Government Medical College, Trivandrum, to the webinar platform. He is a member of the State Medical Board and State Expert Committee and has been at the forefront in our fight against COVID-19. He's also a part of the State COVID Cell. I will introduce the speaker and the topic for the first session. Over to you, sir. Dr. Aravind, sir.
Good morning. First of all, I would like to thank the coordinator, Sunil Matthew, sir, and the secretary, Dr. Harsha, for giving me this opportunity to the chair the very important session on COVID-associated mucormycosis. And we all know that it has been described as a storm in the Indian sky, which is already clouded by the number of cases and fatalities following the second wave, which is actually ongoing in the country as well as in the state. And in order to throw light on, so apart from the unholy trinity of COVID, diabetes, uncontrolled diabetes mellitus, and steroids, we know that there are so many cases without identifiable risk factors leading to COVID-associated mucormycosis in India. In the Kerala scenario also, as of now, we are having around 72 confirmed cases of COVID-associated mucormycosis and around 50 probable cases with a mortality rate of around 30%. So in order to take us through the latest in the field of mucormycosis, especially the COVID-associated mucormycosis, we have a very, very eminent speaker, Dr. Mary John, the head of Department of Internal Medicine from CMC Ludhiana. So such a person does not require any introduction. So welcome, madam. Please take us through the latest in mucormycosis. Thank you.
Thank you very much, Dr. Arvind, for those kind words. I'll just start sharing my screen. Is it visible?
Visible, madam.
Yes. Okay, fine. A very good morning to all of you and greetings from CMC Ludhiana. We are in Punjab. Ludhiana is in Punjab, if some of you all may not be knowing. And here it's in the north of India. And here in Punjab, we have seen more than 350 cases of mucormycosis in the last 1 month. In our college, we have seen around 16 cases. And all of these patients were either COVID or just post-COVID. So today my talk is on mucormycosis and its association with COVID. My talk will be as follows: introduction, predisposing factors, pre and post-COVID mucormycosis, pathogenesis of mucormycosis, clinical presentation, diagnosis, and management. So if we have forgotten, the mucor is a thin, fragile, filamentous mold, and it is of the order of mucorales. It's a ribbon-like aseptate fungus, which has obtuse branching. It's abundant in the environment, especially on decaying organic matter, and it is it causes opportunistic infection. So the tropical climate, like our country, leads to a high spore count, particularly with the hot, humid conditions. And this is what the mucor looks like. So mucormycosis was always thought as a diabetes-defining illness, and was always, definitely we know that it is extremely rare in healthy persons. And we always thought and knew that it is a complication of uncontrolled diabetes, particularly diabetic ketoacidosis. The mortality rates are around 40 to 80% with mucormycosis. And in India actually forms 40% of the global burden of mucor, with the prevalence of 140 cases per million. And this is from Dr. Prakash and Dr. Chakrabarti in Global Epidemiology of Mucormycosis 2019, in this Journal of Fungi. What are the predisposing factors? Firstly, we all know this: uncontrolled diabetes with or without DKA, hematological and other malignancies, organ transplantation, prolonged neutropenia, immunosuppressive and corticosteroid therapy, iron overload states, or even hemochromatosis, deferoxamine therapy, severe burns, AIDS, IV drug abusers, malnutrition, and open wounds following trauma. So in the COVID-19 pandemic, in the early part of COVID-19 pandemic, there were reports of less than 1% of secondary infections being caused by fungi. And some of them were not only due to mucormycosis, they were also due to aspergillosis. Pre-existing diabetes or even undiagnosed diabetes, indiscriminate use of antimicrobials and glucocorticoids saw the emergence of several fungal infections, and severe ones in severe COVID-19. And there were occasional reports of COVID-associated mucormycosis, or CAM, from various centers. And India, with a high burden of mucormycosis, and which also being worst hit by COVID-19, And with many severe COVID-19 diabetic patients, we saw a rising trend of mucormycosis in COVID. This was a multi-center epidemiological study of coronavirus disease-associated mucormycosis or CAM in India by Dr. Atul Patel et al. They studied the cases from September to December 2020, and it was published in the Emerging Infectious Diseases. It was an early press release. They found that out of 287 COVID-19 cases, 187 had CAM. The prevalence, however, was 0.27% amongst hospitalized COVID-19 patients. They also found that it was a 2.1 increase in mucormycosis as compared to the previous year, September to December. So they studied from September to December, and they found that this increase was about 2.1% more than what was in the previous year. They also noted that uncontrolled diabetes was common in CAM as well as non-CAM patients. And COVID-19 was the only disease in 32.6% of CAM. COVID-19 related hypoxemia and improper steroid use was independently associated with CAM. Also, the mucor case fatality rate at 12 weeks was 45.7%, which is similar for both CAM and non-CAM patients. However, older age, rhino-orbital cerebral mucormycosis, and prolonged ICU stay increased mortality. Hence, the COVID-19 pandemic saw an increased cases of mucormycosis in India, and they blamed it, possibly it is because of inappropriate steroid use. So this slide just shows you cases of pre and post COVID-19 mucormycosis. So the pre-COVID mucormycosis, there were two studies. One was Prakash et al. In 2019, which was a multi-center study on 388 confirmed or suspected mucor, and they found 18% had DKA and 15% had uncontrolled diabetes. Patel et al. On 465 cases of mucor found an increased risk of rhino-orbitocerebral mucormycosis in diabetics to be 7.5% fold. John et al. In April 2021, this is not me, saw in 41 confirmed COVID-19 cases, there were mucormycosis also associated. And here, diabetics, it was in diabetes, 93% were diabetics and 88% were receiving steroids. So this is the post-COVID time. And Avadhan at KS et al. In a systematic review of 101 reported mucormycosis, which were 95 confirmed and 6 suspected in COVID-19, found that diabetes was present in 80% and 76.3% of them received steroids. However, there were no studies comparing mucor in non-COVID-19 who did not receive steroids versus COVID-19 patients who received steroids. As we all know, this COVID-19 has been evolving and we have learned a lot of lessons, and we've learned how to manage, we've learned how to prevent some complications, and we are getting wiser as we go on. But sadly, on the, seeing patients getting COVID as well as mucor has been a big learning experience for all of us. What is the pathogenesis of COVID-associated mucormycosis? The use of steroids leads to decreased phagocytic activity. There is accessible amounts of iron because of displacement of protons by transferrin in diabetic ketoacidosis, and the fungal heme oxygenase promotes iron absorption for its metabolism. We all know that SARS-CoV-2 affects the CD4 and CD8 T cells, and severe COVID-19 is associated with reduced lymphocytes and T cells, leading to worse outcomes. Also, the mucorale specific T cells, that is the CD4 and CD8, produce cytokines which are IL-4, IL-10, IL-17, and interferon gamma, which damage fungal hyphae. Lymphopenia, we know, increases the risk of developing invasive mucormycosis. And diabetes with altered cell immunity leads to severe disease due to decreased chemotaxis, phagocytosis, decrease in NK cells, skewed T cell activity, and more pro-inflammatory cytokines, leading to this prolonged inflammatory stage, which we know is the third stage that we have in the clinical course of COVID, and leading to a hyperinflammatory response and cytokine storm. So this is all linked: COVID, mucormycosis, steroid use, the deadly triad. So this ominous triad of diabetes, steroids, and mucormycosis in COVID-19, we can explain as follows. The uncontrolled diabetes with or without DKA, plus the use of steroids, leads to DKA in some. And this DKA, we know there is decreased pH, and this facilitates spore germination and decreased ability of transferrin to chelate ion. Uncontrolled diabetes also leads to glycosylation of transferrin and ferritin, which leads to decreased iron binding and increased free iron, which is also ideal for mucor. Also, the increased cytokines in COVID-19, like the IL-6, lead to increased ferritin. And we've seen this when we do ferritin values, they're very high in patients with COVID. This is because of increased synthesis and decreased iron transport. And steroids decrease the phagocytic activity of WBCs. So if we were to put it in short, high glucose, low pH, free iron and ketones, and decreased phagocytic activity leads to enhanced growth of mucor. This is due to increased expression of the glucose regulator protein, or the GRP78, which is found on the endothelial cells, and also the fungal ligand spore coating homolog, the COT-H, which is the protein enabling protein. This leads to angioinvasion, hematogenous dissemination, and tissue necrosis. And I'll explain this in a cartoon. So this is how the postulated interaction of diabetes, corticosteroids, and COVID-19. Steroids, COVID-19, and diabetes lead to hypoxia. And new onset diabetes mellitus or COVID can also lead to new onset diabetes or undiagnosed diabetes. And this leads eventually to DKA. And as I just explained, DKA is enhanced mucormycosis, thrives in the presence of DKA. Also, with diabetes mellitus, you have increase in cytokines, decreased CD4, CD8, decreased lymphocytes, and metabolic acidosis. And metabolic acidosis again leads to decreased GRP78 and COT-H3. Corticosteroids, on the other hand, also lead to increase in blood sugars, and COVID-19 actually goes into causing acute hyperglycemia, hypoxia, and decreased lymphocyte count, increase in free iron. So all these eventually are intermingled and will lead to mucormycosis. So the common sites of mucormycosis is the rhino-orbital cerebral mucormycosis, that is in the nose, sinuses, orbit, CNS, also pulmonary, GIT, skin, jaw bones, joints, heart, kidney, and mediastinum, which causes the invasive type. So this is a case of rhinocerebral mucormycosis. You can see conjunctival edema as well as lid edema, and there is some amount of lid lag and possible third nerve. This is a case of pulmonary mucormycosis, where you see a reverse halo sign. There's dense consolidation outwards, and inside there is a ground glass opacification, which is very classic. Also, you can see cavitation in pulmonary mucormycosis. So in ROCM, what is the commonest variety worldwide? The spectrum actually is threefold. You have limited sinonasal disease, that is the sinonasal tissue invasion, or you can have limited rhino-orbital disease, that is progression to the orbit, or rhino-orbitocerebral disease, which is the CNS involvement. And areas involved in mucormycosis actually differ to the depending on the underlying condition. So like in ROCM, you have, it's usually found in uncontrolled diabetics and those with DKA. Pulmonary mucor is usually found in patients with neutropenia, bone marrow transplant, solid organ transplantations, and other hematological conditions. GI mucormycosis is usually found in malnourished persons, and skin mucor is found usually following burns and wounds. So this is a proposed mechanism for the establishment of ROC in diabetic patients. Now, if you see this slide, with diabetes, you have high levels of blood glucose, free iron, and ketones. And these ketones cause all these three cause a stress on the endoplasmic reticulum. And here, the GRP78, which is found in the epithelial mucosa of the nose, epithelium of the nose, sinus, and lungs, is overexpressed, and it's relocated to the surface, and it's called CSGRP78. And this CSGRP78 interacts with COVID-19, the COT-H3, which is found on the mucor. And this leads to promotes this hyphae. This leads to the hyphae that can damage and penetrate the epithelium And this enters the lumen and induces extrinsic coagulation pathway. And this in further goes on to leading on to cell damage, thrombosis. And this eventually leads to ischemia, sustained hypoxemia, and necrosis. So basically, it's the interaction between the fungus and this the COT-H3 on the fungus, as well as which penetrates the mucosa, the epithelium, with the help of the CSGRP78. And this all leads on to the eventually leading on to this coagulation pathway, which causes cell damage, thrombosis, ischemia, and sustained hypoxia. And that's what we get this necrosis. Okay. So this is a picture of the hyphae in the blood vessels of a patient with mucor. Clinical presentation is, I'll be talking mainly on ROCM because that's the most commonest one that we see. So you get acute invasive fungal sinusitis where you have rapid proliferation of the fungus, and this invades into the nasal mucosa. The common sites are maxillary, ethmoid, and sphenoid. Symptoms would be fever, nasal discharge, stuffiness, and facial pain sometimes, and swelling. Then you have oromaxillary people presenting with dental pain, loose teeth. So dentists also must be aware that people may present to you with pain in the teeth and loosening of teeth. Please be careful to look around for any telltale signs. There may be eschar on the palate, which is a common finding, and that's how we earlier used to diagnose mucor. Orbit. In the orbit, if it extends, you get lid edema, swelling, chemosis, proptosis, decreased eye movements, and loss of vision. Cranial nerves 2, 3, 4, 5, 6, and 7 may be involved with different syndromes that you have. Intracranial extension leads to altered consciousness, hemiparesis, coma, mycotic infarcts, cavernous sinus thrombosis, and temporal lobe infarcts also. So this is a picture of a patient with eschar present on the palate of a patient with mucormycosis. Here there is conjunctival swelling and edema, as well as lid edema, and some amount of pigmentation also present, black pigmentation also present. This is a patient who has the same, another patient who has mucor. The it's actually ROC type, and she was quite sick, leading to loss of consciousness. And you can see the blackish staining on the skin also present. You may even have complete third nerve palsies. So the staging of ROCM is 3 stages. Stage 1 is if it's confined to the nose and PNS. Stage 2, if it extends beyond the nose and PNS, is resectable. So stage 2 is resectable, that is, it's present in the anterior orbit, subcutaneous tissue, or the pterygopalatine fossa. And stage 3 is it extends beyond the nose, PNS, and is unresectable. So how do we diagnose mucor? We have to do the basic bloods, CBC, random blood sugar, acetone. This should be done in all patients. HbA1c you should do because a lot of undiagnosed diabetics, creatinine and electrolytes. You should do a COVID-19 RT-PCR. If it's positive, good, or not. If it's not, go ahead with the SARS-CoV-2 antibodies. They may give a past history of fever, may have been a mild disease, but went on to having this mucor. Or a rapid antigen test if they come with acute symptoms. CT-PNS with contrast is usually the one that is first done. However, it may not correlate with the clinical findings. MRCT base of skull with gadolinium for the orbital soft tissue and intracranial involvement is the preferred scan. And here you can demonstrate orbital cellulitis, cavernous sinus thrombosis, internal carotid artery thrombosis, and infarcts, cerebritis, and abscesses. So the diagnostic nasal endoscopy is very important. So we have the help of our ENT friends. And here you'll see altered nasal mucosa, and particularly the middle turbinate is the one that is involved, and middle meatus and the septum. You may see bleeding, discoloration, ulceration, and eschar formation. And what we do is a biopsy is taken, and frozen section is the one that is taken out, an urgent histopathological examination to look for the fungal smear and culture. Treatment is also multidisciplinary. So reaching up to here, just making a clinical diagnosis is not enough. We need the help of ENT surgeons. We need the help of the microbiologists. We need the help of the neurosurgeons sometimes. We need the pharmacy to back us up with medication. We need the whole team to continue monitoring the patient. particularly if they're in the COVID wards or even outside, administration of drugs. So it's a multidisciplinary approach and it's a long-term treatment. It's just doing the following. So surgical debridement is very important because you debride the infected tissue and then there'll be better penetration of drugs, and it also decreases the fungal burden. You must remember stage 3 is unresectable. So once it's gone into the CNS, most of the times the patient is also very sick. I think we will be just hastening death by going ahead and removing whatever fungus is there. So stage 3 is particularly in active COVID is possibly you just leave them alone, and because it's already reached a stage of no return. You should control the diabetes and if there is diabetic ketoacidosis. And the third means to stop the steroids if you're giving any immunosuppressive drugs. And the last definitely is antifungal therapy. So antifungal therapy is given for 4 to 6 weeks. The drug of choice has always been amphotericin B, and we've all used the deoxycholate, and we know the toxicities are associated with it. But in our country like ours, that is the only affordable one. Otherwise, people will just leave the treatment halfway through. Most of the time, when we start liposomal amphotericin, that is the main cause of stopping treatment. So if you are to give injection liposomal amphotericin B, the dose is 5 milligram per kg in 500 ml of 5% dextrose over 3 to 4 hours that's a repeat. And if there is CNS involvement, remember the dose is 10 milligram per kg. In lipid complex amphotericin B, the dose is 3 milligram per kg IV in 500 ml of 5% dextrose over 3 to 4 hours. If you're using injection deoxycholate amphotericin B, the dose is 1 milligram, 0.8 to 1 milligram per kg IV in 500 ml of 5% dextrose over 4 hours. Please administer through a central line, and also pre and post amphotericin, before you give ampho and after you give, adequately hydrate, preload the patient with IV normal saline 500 ml before and even after 500 ml. Also pre-medicate with Avil and paracetamol, because you know that a lot of patients have reactions to this amphotericin B. Potassium and magnesium supplementation has to be given, because we know that this does cause hypokalemia and hypomagnesemia. Check the potassium values, magnesium and creatinine every other day. It should be done. Continuation phase is tablet posaconazole, 300 milligram BD for 1 day, and then 100 milligram OD it's 300 milligram OD to continue, not 100 milligram, it's 300 milligram OD to continue. And tab isavuconazole, if it's available, 200 milligram BD for 1 day, then 200 milligram OD. And this has to be continued up to 3 to 6 months with regular follow-ups with the ENT surgeon and reviews to be done. It's not that it's only the treatment with medication. We also need the surgeons to help us to see the healing process, and in case they need to go in again. So the take-home messages that I have is India has seen an increase in COVID-associated mucormycosis, and please, it's not black fungus, though it appears black. It's been a misnomer in the press and other places. And this increase is because we have seen a lot of immunocompromised state in COVID, along with immunosuppression with use of steroids. So we also seen that India has an increased diabetic population with uncontrolled and undiagnosed diabetes. We also had a high load of COVID-19, and we had a very high indiscriminate use of steroids. So these three factors have really precipitated the mucormycosis post-COVID that we are seeing. So early diagnosis is actually the key to successful treatment with a good clinical examination, particularly when patients are admitted during and post-COVID-19. When they have been followed up also, please ask them on discharge to just tell them that if ever they report any facial pain, any excessive watering, any nasal stuffiness, they should come back as soon as possible. And the management, as we saw, was surgical debridement, stop the steroids, start antifungals, and good glycemic control. I think that's the last slide. Thank you very much for your patient attention.
Thank you, madam, for the excellent coverage of COVID-associated mucormycosis. You have taken us through the epidemiology and the most important aspect, there's the pathogenesis and the controllable factors, which leads to the multiplication of the hyphae inside the body, as well as through the treatment. I think we can take questions at this point of time. Thank you for finishing before the stipulated time. We have enough and more time for discussion. So, Dr. Harsha, I am not seeing any questions in the chat box. So, if anyone wants to clarify anything, you can ask now.
Can I have a question?
Sir, actually, sure.
Can I have a question?
Sure.
Sure, sir.
Actually, I am Dr. Vijaykumar from Pandalam. Regarding from an epidemiological point of view, actually the cases of mucormycosis very much increased after the COVID-19. Before also, we were seeing a lot of, for the last 40 years, I am treating diabetic patients. We were seeing uncontrolled diabetes on steroids also. Some of the times we have to give steroids for them also, for other diseases. But hardly, I have never seen a case of mucormycosis in my entire career so far. But is there, from an epidemiological, is there any other cause rather than the things which we have discussed for the cause? Especially, I am pointing towards the indiscriminate or unhygienic use of masks. Have you tried to analyze the mask, whether the patient was using, to see whether the fungus was there? Because our climate, we know the humid climate, the growth of fungus in the mask and the use of mask, actually, it is better said, less said, the better. How they use the mask. So, have you looked into that angle?
Actually, looking at, there are ongoing studies actually, even in our part of Punjab, we are starting this thing on mask use. What you said is a very valid point, because the cotton masks, and they're not washed and they're not dried properly, and the spores may be there and may just get into patients with COVID. Instead of protecting them, it's causing them harm. So definitely mask does play an important role, but I do not have any studies to look into that, because it's going to be very difficult in one point, because people might deny also, everybody's in a denial mode. Even if you ask them if you have fever, a lot of them are coming into our OPD with fever and they are diagnosed with COVID. They know they have this, but they just slip into the outpatient. So same way, mask use is a good thing to ask for, but I'm not sure. Yeah, it will be definitely associated with it. To find an association would be a good question. Yeah, I have to go into it. That's a good thought. Yeah.
Madam, actually, Vijaykumar sir, the government of Kerala has started a sort of a RCT, because all the patients are not having this diabetes and steroids. The largest case series of the observation studies from India, 83% are having diabetes. Around 17% are not having diabetes or use of steroids. But then definitely the genesis of CAM is multifactorial. Steroids is one arm. The uncontrolled diabetes is one arm, the COVID is the other arm. These are the three significant factors. There are so many other things, because we are inhaling the spores every day. So it is ubiquitous. So it need not be from the mask itself. Once the spore is there in the nasal epithelium, usually the bacteria which is there to suppress the fungal growth, that is lost because of the indiscriminate use of azithromycin. And because of excessive steam inhalation, the nasal immunity is lost and there are scalds, and it can get into the inside of the nasal epithelium. But still, if our phagocytic activity is pretty good, it need not be a problem. So, but then in the setting of the diabetes and COVID, the phagocytic activity is also lost. So it is a truly multifactorial thing, sir. Even with an RCT, it may be pretty difficult. When we analyzed the around 70 cases in Kerala, so majority of the patients who had come from the neighboring state, they used to do steam inhalation around 6 days, thinking that will prevent them from getting COVID. And for the steam inhalation, they had used turmeric, tulasi leaf, and clove. We know that if we keep turmeric outside, there will be spores inside. But it is actually truly multifactorial. But even with an RCT, it might be very difficult, because we are having, say in Kerala, is 25 lakh cases of COVID-19, and we are having only 72 cases of confirmed COVID, and majority of them will be taking the steam inhalation, azithromycin, etc. So we need to keep all these aspects in mind, but it is truly multifactorial, the genesis.
The simple culture of the mask, fungal culture from the mask.
Sir, it has been done, sir. It has been, actually, we have done that. And it is easy to grow this fungus when the mask is not using properly. That is why all the guidelines are sticking on the mask etiquette as well as the mask hygiene. You should pay attention to that, especially in diabetes and all. We are advising that you should not reuse the mask. That is, those who are immunosuppressed, they should not use, and they should not visit these construction sites also. Construction sites is full of these fungal spores. Thank you for bringing these points.
Sir, we have a few questions.
Harish, hello, 1 minute. Can I ask a question?
Sure, sir.
What do you think about use of zinc? People say zinc also. Is there any problem for zinc, madam? Or And I don't know whether there is the quantum of the amount of fungi which is exposed. No, normal people do not get it, no, but only immunocompromised people get it. Then is there a difficult difference in the amount of exposure? Have any study has been done? Because if the fungus is grown in the mask, the amount you are postulating that the amount of exposure or quantity of exposure will be more for that person. Is there any study going on like that? And what about zinc also? Zinc. Everybody says use of zinc. Anything?
I think zinc has been taken off, because some studies have shown that it has promoted it,
Yes.
and the mask part of the pH, what I just described, the pH in a diabetic, especially the lower pH, that increases the multiplication of these spores. And normally, if you and I inhale it, we do not get it, right?
Yes.
In this milieu of decreased pH, increased iron, in COVID. So this is what they're saying, that COVID-19 definitely has a part to play in the pathogenesis of mucormycosis, other than diabetes, to steroid use, which has other pathogenic mechanisms also. So this is what I can do. I don't know, Doctor.
Ma'am, we have a few questions in the question answer box as well. Most of them are asked. We have somewhat similar COVID treatment modalities across the world and even in India. But then why do you see some regional variation, as well as why do you have more prevalence of mucormycosis in spite of the patient being not diabetic? And some people have asked whether there is a role for steam inhalation as a cause for mucormycosis.
I think this is already answered. We talked about steam.
Yes, ma'am.
And steroid, maybe, we don't know. Some of them, a lot of them have used and not disclosed to us also, I'm sure, because steroids definitely decrease the neutrophilic, the activity. So we do have patients also decreased, so CD4, CD8 also decreased. So then you can have increased chance of getting mucor. That's what I think.
Ma'am, another question which is very common amongst the audiences, is there any relation with the variant of or the particular strain of virus that is found in India? Is that why we have more of mucor in India rather than the rest of the world?
Actually, they're trying to look at these samples of patients. I haven't come across any report, particularly the new strain, the Delta strain, they found because it was more infectious. So more number of people and then more number of mucor. So I think it's just the denominator that increased. Proportionate rise and notification. And we have become aware of it. So last time, we also had a few cases, but we thought, okay, part of COVID. But when all these facts started coming out, we've all learned this all the way and up to the stage. So I think that is the problem. That is the explanation. It's just that the denominator has gone up. And now that the denominator has gone down in our state, we're seeing lesser patients.
Yes. Yes. Ma'am, there are the other questions are almost.
One more question I have from my side.
Yes.
Madam, I am a pulmonologist and working in Pushpagiri. So most of the patients, we have been for a long time giving steam inhalation. Now, what should I tell my patient? Next time when he asks me whether I should do steam inhalation, because we almost religiously tell them to do steam inhalation once a day or so in almost most of the patients with respiratory infection. And they do take it also because it is the custom. Because even my grandmother used to say, you take steam inhalation. So what should I tell the patient? What do you think? What should be the take-home message? Because steam inhalation.
So this is preventive, or is it what you're trying to say? Preventive?
No. If suppose next patient of COVID asks me whether I should take steam inhalation.
I don't think you should promote it, because that moistness and all that goes into, and also the mucosal barrier will break,
Yes. So better not. Thank you very much.
But I want to ask one question. If we take the incidence of COVID as well as mucormycosis, the incidence of mucormycosis is more in the northern states. Why it is so less in southern states?
Southern what? Southern states?
Yeah, southern, that is in Kerala. It is the incidence is less actually when you compare to the northern states.
No, actually, what we've seen in our pandemic here, patients have been coming very late. I think the awareness down there is much more. Here it's spreading to the villages, and we've seen the second wave is more in the villages, whereas your community, I'm very happy to say the community medicine there in Kerala is much more, even other southern states is a very good community medicine that you have. Over here, it has been more in the urban areas, which we first had, and then Very few were in the community. Now with this second wave, we've seen more patients in the community, maybe because of all this farmer agitation and people moving up and down to Delhi, North, they keep going in circles. One person goes, one family goes, they stay for some time, they come back, they may be bringing. So we've seen a surge, and it's the farmer population also, right? So a lot of them don't come to the hospital because they're scared of getting admitted. They don't come, and they come in very late stages. So COVID itself, we have seen patients presenting very late. They don't come in the early phases at all. And they hide, they don't come. And then, so that's why maybe we're getting the sick patients that are coming in.
Two questions. One is regarding the serum ferritin level. Serum ferritin level in COVID has got any connection with the mucormycosis?
Yes, it has. You have very high levels of ferritin levels in patients with severe COVID and also in patients with mucormycosis. I explained the pathophysiology, that it is increase in free iron. We just saw that, So there is definitely a correlation. But I don't know any studies, but definitely the serum ferritin levels are very high.
Suppose if we take the mucormycosis instead of in COVID, those persons who are getting steroids and became diabetic after getting the steroids, and comparing the patients with already on diabetes on steroids, which patients are prone to develop this mucormycosis?
So like I told you, there has been no studies done on patients who have had no diabetes and diabetic with steroid use and no. You're saying with steroid use, both of them.
With steroid use, they became diabetic with steroid use.
They become diabetic with steroid, but then usually we do an A1C, and then we see that they are already diabetic or not. So a little bit of hyperglycemia. That's why they say control the hyperglycemia. I'm not aware of any studies of acute COVID and just acute diabetes happening and incidence of mucormycosis. That's what you're trying to ask, right?
Yeah. That's the question actually.
Ma'am, there is some questions in the YouTube. Just I will take it up, ma'am. Ma'am, is there an increased risk if we are supplementing iron both oral and in parental to a COVID patient? By Dr. Devi Prasad.
I am not sure on that. Dr. Arvind, do you have any answers for that?
Thing is, we need to see whether the iron or the IV iron is needed in such a patient. Majority of the COVID-19 patients don't require any iron supplementation. But most important thing is we don't know much about the real risk factors apart from diabetes and steroids leading to the pathogenesis of CAM in India, because majority of the risk factors which you have discussed are there in other countries as well. Like the variant is there, diabetes is there, as well as steroid use is also there. But there are certain other factors which are pertinent to our subcontinent, even in our neighboring countries like Pakistan, which have very high cases of mucormycosis, which are not related to COVID. They are not seeing a spike in COVID-associated mucormycosis. So whatever is not needed should not be administered. 96% of the patients in Kerala with COVID-19 does not require any treatment. They just require close observation. That is what I have learned from over the last 2 months in treating with COVID-associated mucormycosis. And even in Kerala, it is a problem. Compared to our background rate, we are seeing more and more cases of COVID-associated mucormycosis. In Tamil Nadu, we are having cases. Karnataka, there is a huge spike. So South is also not spared. Comparatively, lesser numbers are there. Northeast is spared because for the fungal germination, etc., the humidity and temperature axis is also important. So South is also not spared. We are seeing a spike. Whatever is not needed in the treatment of COVID-19, we should not use it.
Actually, we've learned that, isn't it? You don't really need to give anything when they are in the level 1, that early part. You just don't need to give anything. And only when they come into the hospital, that also you have to be very careful. Even indiscriminate use of antibiotics, that has been, all high-level antibiotics are started. Those also have to be taken care of.
Definitely, madam.
Thank you, ma'am. Thank you, sir. Thank you, Mary, ma'am, for such an informative talk and patient answering to all the questions. We still have a few more, or rather so many questions in our question answer box. But then I think at the end of the session, if at all time permits, we could have an open house. But otherwise, I think we had a good discussion. Now, moving on to the second session, I would like to invite our chairperson for the second session, Dr. G. Vijaykumar, sir. He's a senior consultant physician and diabetologist working at Medical Trust Hospital, Kulanara. He's a great clinician with profound clinical acumen, and his area of interest is diabetic food
and he has given a great contribution in the field of diabetology. He was also the president of API Kerala chapter. Sir, respected G. Vijay Kumar, sir, I invite you to the platform, and sir will introduce the topic for the second session and the speaker for the session. Thank you.
Thank you, Dr. Harsha. First of all, let me thank my friend, Dr. Sunil Matthew, for inviting me to be part of this elite group of faculty. I think this is a very important webinar which we are witnessing. The next topic is on metabolic control in COVID-19. The topic will be covered by Dr. Thomas V. Paul, who is the professor and head of the Department of Endocrinology, Christian Medical College, Vellore. He is well known to all of us as a great academician, teacher, and a researcher. His area of interest is metabolic bone disease, especially osteoporosis, and he is the principal investigator for multicentric trials in osteoporosis.
Oh, okay, thank you.
He is a reviewer of many national and international journals. He has more than 170 publications in national and international journals. And he was awarded the T.N. Shah Oration in ASICON 2017 and Nadarajan Oration in Jericon 2019. He is a member of ESI and he is at present president of the Endocrine Society of Tamil Nadu. Coming to the topic, actually, the importance of this topic is known to all of us. Metabolic diseases like diabetes, obesity, and hypertension have emerged as the important risk factor for severe COVID-19 infections requiring ICU admission or intensive care. But the mechanisms responsible for this are mostly unclear to us till recent times. In the beginning, COVID-19 was thought to be a respiratory disease primarily, but our knowledge about this has evolved over the last 1.5 years. Now, it can be considered as a facilitator. COVID-19 can be considered, metabolic diseases can be considered as a facilitator of complications of metabolic disease. COVID-19 is a facilitator of the complications of metabolic disease. Now we know that COVID-19 affects microvascular circulation and coagulation process. So COVID-19 becomes severe when it affects a metabolic patient whose microcirculation is already in problem. This COVID-19 pandemic has alerted us to the vulnerability of our patients with diabetes and other non-communicable diseases, obesity and hypertension, who share a diseased microcirculation. For example, there's a come across a study recently that showed that people with diabetic retinopathy have a 5-fold increased risk of ICU admission compared with patients without diabetic retinopathy. So the health of the microcirculation is very important. The metabolic control in COVID-19 has basically three components. Management of hyperglycemia while the patient is having the disease, that is during the COVID-19 infection. Second is we are seeing a lot of COVID-19 patients who become dysglycemic once they recover from the COVID-19 infection. What is the fate of this newly onset diabetes, and that we have to see. And also another important component is the importance of keeping a good metabolic control in high-risk population is also very important to prevent the severity, to prevent the COVID-19 getting severe in patients who are already on treatment for metabolic diseases. In short, we have to keep a healthy microcirculation in them with an aim to mitigate the damage if at all the COVID-19 affects them. So I invite Dr. Thomas Paul to have his presentation on the metabolic control in COVID-19. With his rich experience from CMC Vellore, we are looking forward to clarify a lot of our doubts. Over to you, Dr. Thomas V. Paul.
Thank you very much, sir, Dr. Vijay Kumar, and very good morning. At the outset, I'd like to thank Dr. Sunil for inviting me for this wonderful session. Lots of, when we do interaction with Kerala physicians, it's little like my metanephrine goes up because full of profound knowledge, and I am from Tiruvalla Naranam, so that also, though I am not physically present, I remember my native place also. And next 20 minutes, I just wanted to briefly go through this metabolic control. When we talk about metabolic control, we always think of hyperglycemia, but I put some cases where we little bit of problem we had with some of the cases after COVID also. So I'll just start. When we talk about pandemic, we talk about all over the world. So this map has been shown anywhere. Everywhere in COVID talks, this is there. So when we talk about obesity and diabetes over last 20 years, this is the map we are seeing. So we are talking, this is one of the beautiful article which came, everybody should read this. This is interconnection, intersection, crosstalk between this hyperglycemia, obesity, cardiovascular disease, neurodegenerative disease, osteoporosis with COVID-19. That is infection. That's what we are just looking at. Now, this is already evident. Like, many diseases are being like this. For example, if you take a age-old HIV, we know it affects bone. Age-old HIV, it affects lipids, its treatment especially. So there is always a crosstalk between infection and non-infection. So when we talk about this in COVID, we know there are metabolic diseases already existing which interact with COVID-19 or COVID-19 per se causing problem. And the third aspect is medications which we use to treat certain, especially moderate to severe COVID infection. Now, this is one of the earliest slides, like the documentation of many comorbidities in addition to hyperglycemia, like hypertension, chronic obstructive airway disease, cardiovascular disease, kidney disease, liver disease, osteoporosis, malignancy. All this have taken back in COVID-19. Some of them have gone into the management to the backside. Now, it's not now. If you look at 100 years back, in 1918 flu, if you look at it, obesity and hyperglycemia were the important factors which had a higher mortality duration. Even the last H1N1 10 years back, same thing. It's not new for us. Why we are highlighting this? Because we are seeing more and more number, more and more morbidity and mortality. So this was one of the earliest reports stating that people getting admitted for the first wave were above 50 years and equal men and women. Why this slide was important? In India, we are talking about little younger population, not above 65. In Western, all these comorbidities were widely quoted, like hypertension, obesity, lung disease, diabetes in this 50 to 65 years. That is what Dr. Vijay Kumar was highlighting. In fact, that associated mucor also Dr. Mary John was highlighting. So this is where we have problem. Now, if we go to the hyperglycemia, this is a case, is a garden variety we have, we are seeing nowadays, and this is everybody has seen. Severe COVID, glucocorticoid, pre-diabetes earlier, now patient is having frank diabetes. Even Dr. Mary John was telling about this, treated with insulin, and now patient is requiring only metformin. This is about 2 months from now, this is one case. The second case is a police officer from our place. He had mild COVID and he had a home management, only paracetamol, that's all, and recovered. But he's noticing increased thirst, calling us and noticing the glucose of 342. This is what the new entity. As Dr. Merijan told, we have done HbA1c 5.9, nothing great. So, we did a C-peptide, reserve is there. Here, no ketosis also. Patient, we have started on metformin and glycoside, could have started on DPP4 inhibitor, but thing is, this is a choice we made. And patient is doing well. New onset after recovery from COVID, we are seeing quite a number of subjects without anything happening during COVID. This is another patient, very well documented to taken steroids for 14 days. I'm not sure why patient was given 14-day steroid, presenting to emergency with upper abdominal pain, no addiction, no alcoholism, no comorbidities. The emergency department medical officer suspected gastritis. Of course, pancreatitis and gallstones were in the back of the mind, but patient had pancreatitis. First time calcium profile is normal, triglyceride is high. So picking up high triglyceride induced pancreatitis and would have been precipitated by glucocorticoid. Now, when we talk about diabetes, as we mentioned and previously mentioned, maybe a suboptimally controlled diabetes in COVID, or we are first time picking up already existing diabetes, or pre-diabetes was there, steroid is unmasking, or HbA1c is normal. During COVID, we are picking up COVID-induced diabetes, or the last entity, after recovery, we are picking up post-COVID diabetes. Now, this is a beautiful slide made by my colleague, Dr. Nitin Kapoor. So, COVID talks to diabetes, diabetes talks to COVID. The factors are highly illustrative. So, this is what we do see. This we know for last 16 months at least. Now, this entity, patients in this way, we are seeing that the subjects are presenting as ketoacidosis. We all know ACE receptors are there in beta cell. This virus go attack beta cell, destroy insulinopenia and ketoacidosis, new onset. Or in diabetes, already there, type 1, it is presenting as a ketoacidosis. This entity we are seeing. As Dr. Vijay Kumar spoke, all this microvascular complication pathway get accelerated. We do see in post-COVID recovery in diabetes, neuropathy symptoms are worsening after 1 month. That entity also we are seeing. We don't have a data on retinopathy, at least neuropathy is a physician assessment. So we do see worsening that entity. Now, new onset diabetes, it can, we all know that it can unmask pre-existing diabetes, cytokine induced beta cell, and especially many patients after recovery. The message is after recovery, some patients can get. We don't have any prediction at this point of time who will get diabetes. It is prudent to screen at least people above 45 for this. Now, this is one of the earliest study. Outpatient or hospital, 10 to 20% prevalent diabetes. In dilate study, this is only published study at some months back, 50% hospitalized people had pre-existing diagnosed diabetes, and new onset diabetes was seen in about 5.2%. Now, this is a meta-analysis done. Though the heterogeneity is more than 75%, this is only available data looking at the new onset diabetes, new diagnosed diabetes is as high as when you had about 15 pooled studies, 15% had newly diagnosed diabetes. Now, we all know this important study looking at a pre-admission predictors, male, Asian race, obesity, and old age were associated with severe disease. This is old data. Even for the first wave, it was true. It is true for the second wave. Now, this is the medical MD trainee teaching, as Dr. Mary John told, impact of mucormycosis in the interaction. You can see that mucormycosis is coming into picture. In addition to poor glycemic control, diabetic related complications, and it is the more viral entry, etc. Now, we know on the one end, if the glycemic control is optimal, many people survive, very few mortality. When in the on the other end, poorly controlled diabetes, age advanced, 11% mortality. Of course, we advise diet, medication. The physical activity part may be limited in this acute COVID setting. Now, we talk about glucocorticoids. Rampant use we do find. We don't know why they use it in mild disease. It does lots of damage. So the hyperglycemia, unmasked and mucor, everything is there. So this is the rampant, and also many patients are taking for weeks together. That is the main problem we are facing. Methylpred, dexamethasone, prednisolone, these things. Now, this is the what protocol. Initially, everybody getting hospital is easy. We monitor. If a patient progresses or any new medication started, then it is prudent to rescreen for hyperglycemia even during admission or as an outpatient monitoring, home monitoring. Now, this is one of the very good article which is published in Nature Review, very nicely illustrated what medication in diabetes, insulin across the board. But I will be using caution in using SGLT2 inhibitor. There's no very adverse studies, but I'll be using caution. Metformin, definitely no. SGLT2, definitely inhibitor, not in the severe, moderate to severe. But other drugs, we have to be a little cautious. So insulin across the board, but in a mild home observed COVID, we can continue the pre-existing drugs. Now, regarding insulin, we know that COVID cytokines, there is a profound glucose toxicity, profound insulin resistance, defective insulin secretion, all. And we find that insulin requirement initial period is more in our clinical setting. All the more if somebody is on glucocorticoid, it doubles up or triples up. That's what we find, especially during this COVID wave. Now, coming back to 3 cases, the first case was a straightforward glucocorticoid unmasking diabetes, given some infusion, then patient refused, then we gave premix. Currently, patient is on a follow-up outpatient, only on metformin. Second patient, new onset diabetes on follow-up, we giving only glycoside and metformin. So patient is doing well. The third one, pancreatitis, steroids was there, high triglyceride, unmasked, post-COVID. We gave insulin infusion to bring down the triglyceride, and then we added fenofibrate. This patient also got discharged, doing well. So management is in. So the post-COVID follow-up is very important entity, especially for above 45 years. We have to be very aware of newly diagnosed diabetes. All hospitalized subjects to be followed up, and it has to be recognized, and management should be as per the local protocol. Coming back to the hypertension, this is entity also classically described in December 2019 itself, almost going to be 20 marks. So we know it has severity, medications, all this have been more with this hypertension and the morbidity. There are several studies which are projected, which says predictor of outcome. So many postulates, none have been proved. There is an initial concern. In fact, I was having severe COVID. I was on telmisartan, whether to continue or not. That was a question. I continued. I'm alive. But so there is the studies now there, irrespective of antihypertensive medication. All medications can be continued, whether it's ACE or ARB. There is no difference in the death or other adverse effects. Now, coming to the obesity, this is one of the earliest thing which was talked about. That is, more obese, there is more time they shed the virus, they don't clear virus, and the mutants are more seen in obese people. All this have been there. And even it has been described in all epidemic, endemic, and pandemics. Now, we know also even in our setting, we find that ICU admission and need for ventilation in significant proportion happens in the obese people. There are 2 meta-analyses highlighting even the BMI more than 23 in Indian setting carries a risk. So the problem here is prevention. After that, there are two meta-analysis I'm talking about, which is called this. And even OSA, of course, Dr. Malabhagej may touch on the respiratory thing. We find more respiratory failure, more the eightfold COVID infection, because the clearance is very, clearance doesn't take place in severe obese people. And what you do, even after recovery, in appropriate setting, we should start structured physical activity and dietary modification, because this is one post-COVID important aspect we have to be aware of. Now, coming to the next important thing is this is also very important. This case came April 2021, diagnosed as COVID, 61-year-old lady, 6 weeks of dexamethasone, no indication. I'm not sure what was the indication. Stopped. Patient was on diabetes on only oral drugs. Glycemic control was okay in spite of, I think it was about 7.8. This patient is presenting to emergency with vomiting and dizziness, hypotensive, tachycardic, no features of sepsis. You can see in the sodium hyponatremia, and the very intelligent casualty medical officer sent one random cortisol, which is hardly detectable. This is also we are seeing abrupt stopping of steroid after 2 to 3 weeks of it. You may see after COVID, post-COVID hypoadrenal state. Please advise them gradual withdrawal. If patient is on, for example, more than 5 milligram, make it come up to 5 milligram of, I'm talking about prednisolone, then you go to alternate day and stop it over a period of 30 to 45 days. And stress protocol, especially this question asks, somebody on a long-term steroid on a small dose, what to do during vaccination? Double the dose, because many people will have fever, that is a stress. We advise them to double the dose. Somebody is on prednisolone 5 milligram, ask them to do it as 10 milligram for 2 to 3 days. And this we give to everybody for a stress dose. This we can give it after, in COVID patients who have used steroids for more than 3 weeks. We should be careful in suddenly stopping high dose steroid. Now, coming to my topic of osteoporosis, the last bit. So this is a very sad story of a 72-year-old lady left in pain following trivial fall. You know what it is? Patient has got a fracture. Diabetes for 21 years, luckily optimal control, significant neuropathy. She also forgot to mention cataract surgery, hypertension is there. She had right hip fracture earlier. She had severe osteoporosis. She developed a fever with bisphosphonate. She was not willing for daily injection of anabolic agent teriparatide. So we had to give denosumab along with calcium and cholecalciferol. What happened was patient couldn't come. You know that denosumab every 6 months, patient could have got it from the local medical store. No, last dose was August and no further dose was given. You can see this patient sustained left hip fracture. And this patient had to undergo surgery. The sad story was this patient, when reached home, there was a sudden cardiac death. So this is one of the ignored. We always think about diabetes. No, this is also important. All non-communicable diseases have to be aware of. So this is a very nice article. If time permits, please go through this by Rory, Clifton Black. And telemedicine plays a very important role for us. Everybody is doing. Of course, in diabetic foot, we cannot do, but most settings we can manage, even in post-COVID, and educating the physicians as well as you're doing. And also, this has been proved to be very effective. And we know that in addition to physician, our educators also play an important role in educating them, adjusting the dose of medication, including insulin, to bring control of sugar, either pre or post-COVID. Now, so very important, my last 2 slides, more need for appropriate management of all metabolic, not only hyperglycemia, even hyperlipidemia is very important. Steroid, you have to be aware. And very important, it's a work, it's a teamwork. Physicians, diabetes specialists, general practitioners, students, us paramedical workers, diabetes specialists, nurses, dietitians. It's a pandemic, and post-COVID care is very, 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 very important. Now, significant impact, and just think about very rare complication like triglyceride, new onset diabetes even after recovery, and hypocortisol. Somebody received a steroid, stopped, you may face a patient in casualty with hypotension. These are the things we have to be highlighted. Thank you very much for the patient listening.
Thank you. Thank you, Dr. Thomas Paul, for enlightening on all the important aspects in the management of COVID, in the COVID care, as well as in the post-COVID area, in the metabolic control. Actually, we had 2 cases of toe gangrene last week. Oh. Actually, the patients glycemia was controlled. They had COVID infection 1 month, within a month. And the toe, suddenly one fine morning, he noticed the gangrene of the big toe. And one patient, and another patient had 3 toes gangrenous on the same day. All these developed within 1-2 days. Acute ischemia of the microcirculation. Actually, the AB index to the toe up to the foot was normal. Oh. So there was no ischemia of the bigger vessels. Only thing is the microcirculation. Toe was gangrenous. And I think we are going to see a lot of such cases in future for our diabetic patients. And also, as you said, we had a few cases of new onset diabetes, which fortunately were controlled very soon. Like you said, very high blood levels to begin with, but very, very fast return to normal with metformin alone, or even one patient even without any drugs after 1 month. So regarding the screening for actually in Kerala, the age is coming down. Age of onset of diabetes is coming down. Now we are seeing a lot of patients. Our age of onset is actually 30 or 35. We had a study when 40% of our diabetic patients develop diabetes before the age of 45. So we have to screen them even from the age of 30. So that is there. Thank you very much for highlighting all these points. Any queries?
Dr. Thomas Paul, excellent presentation.
Yes.
Thing is that suppose if a patient with a diabetic coming to the COVID, and patient on oral hypoglycemia is well controlled, and if the patient is started on prednisolone and needs oxygen inhalation, so in that case, still if the oral oral hypoglycemia is well controlled, is it necessary to start the patient on insulin?
Yeah. So what we follow, and of course I can get expertise from Dr. Mary John from Ludhiana aspect also. See, somebody well controlled, and also Dr. Vijay Kumar is also there, and Dr. Harish, my friend, is there. So it's a consensus decision. What we do here is, when the patient progresses to severe, sir, we don't give we are discontinuing metformin. So that definitely what is happening is after 48 hours, the glucose levels are going above 300, warranting insulin, sir. So if it is a mild case, we don't start steroid, so we are continuing. We don't touch that. But we progressing, needing oxygen, here in almost all setting, we are stopping metformin, sir. That is our practice. Of course, I'll take the opinion from Professor Mary John also.
So actually, we stop metformin, particularly in patients who are hypoxic, isn't it? That's the
Yes.
Especially with severe hypoxemia, it's advocated that you stop and start on insulin, right?
Yes, that's what I think. Needing oxygen therapy, sir, definitely we are stopping, sir. Though it was well controlled, we are giving insulin. And one more thing I wanted to tell you was totally unrelated to this topic. Please overuse this cholecalciferol. We had 2 cases of vitamin D intoxication. I think it is everybody, like hypercalcemia. Patient not died of COVID, died of hypercalcemia due to vitamin D. This patient, I was given Architol injection 6 lakhs for 30 days. It is 180 lakhs. Patient came with 16 milligram of calcium, creatinine, did everything possible. Patient died. So it was not COVID. It is COVID fear vitamin D. Please, that is another thing I just thought I'll tell you, because don't over treat. There is no evidence to say cholecalciferol optimizing at this point. Everybody can go through. There is one nice article on Lancet Endocrinology, vitamin D and COVID. It's very nice. It's in February. We can see there is no. But if you want to give as usual dose, not in this therapeutic during this infection, I think you also agree. I think Dr. Vijay Kumar and Dr. Mary John, we won't overtly correct at this point of time.
Sir, I wanted to ask that question. Vitamin D, actually, what is there any role in
No, sir. No. There are two meta-analyses already, one from Australia, one from review from India also. No, sir.
Should you look into the vitamin D level in those patients? Should you see the vitamin D level in such patients?
No, sir, see, there is an article we published from our center 7 years back, GBM, that Journal of Bone Metabolism in Critical Care. It's a U-shaped. When the vitamin D less than 4 may be increasing mortality, vitamin D in Indian population more than 40 also increase the mortality. It's a U-shaped curve. So we have to be cautious.
So what is your take on dysautonomia in COVID? Because we're seeing a lot of patients when they're recovering, and moment you make, they have platypnea and orthodeoxia. So the moment they get up and sit, they desaturate. But after that, when they're recovering also, we're seeing that their blood pressures are going down. Those who were on antihypertensive, we are taking them off. BP,
absolutely.
Tachycardia. So is there any role of using fludrocortisone? And these patients are on, is there any role of using fludrocortisone?
I think there's a very valid question. In fact, I also had the same problem because I was on a good dose of antihypertensive after my severe COVID. For 6 weeks, my BP was 90/60. And there are so many patients, as rightly said, not on antihypertensive. But after what we find in our subjects where we have taken off antihypertensive, when they come for follow-up after 4 weeks, BP starts shooting up and it is going to the pre-COVID. That's a very valid point you brought it up. Very valid point. But we are not used fludrocortisone. Our experience is almost zero. We don't know what will happen. I'm not sure. So I'm not used to it.
Any questions from the chat box?
We have one question from Dr. Dheeraj. The question is there any autoimmune damage to the pancreas that's causing the post-COVID diabetes?
So the autoimmune damage means it's a direct damage. There is study which is looking at, actually this is a study in Denmark which is currently going, what happens to autoantibodies following COVID, but that is a very, it's not published any result. So in other words, the data at this point of time is unavailable. So far what is available is a direct destruction through either cytokine or virus to the beta cell. The autoimmunity part, at least by December, we'll get the data from Denmark.
Thank you, sir. So we have one more question. The question is that whether the patients can develop diabetes secondary to COVID vaccination. Are there any reported cases?
No idea. No idea. I think all of us can answer. Dr. Sunil, Dr. Vijay Kumar. We have we published our letter to editor, director, and team in Mayo Clinic. We don't see a single case. We are not seeing. No. This is 7,000 in our own health workers. No nuance.
That's right.
That's what from the audience side, sir.
Any questions from the YouTube?
Sir, in COVID and the type 1 diabetes, is there any specialty we have to look for this diabetes?
Sir, this way, what we're finding is they are coming to us type 1 diabetes. Younger, of course, Dr. Vijay Kumar told the screening. We also do screening, though we practically say at least 45 earlier screening because all things are there. What we are finding is they are coming with the DKSR for their dose itself. Their dose. Probably they are become absolute insulinopenic because of direct COVID impact on whatever the beta cells were there. We are seeing them as a DKA. So what we advise is we have a good specialist. My colleague Dr. Asha is looking into type 1 diabetes in all the subjects, calling every week, adjusting the dose of insulin. We have 300 subjects and almost make sure that once a month everything. So your question is valid, sir. The requirement is going up.
Any questions from the audience?
No, sir. No.
Thank you. So let us thank Dr. Thomas for an enlightening session. On a lighter vein, we should advise our people to have a healthy microvasculature, at least our next generation, like the vasculature of the 1970s, where the prevalence of diabetes was only 2% and the obesity was unheard of. So let us strive to have such a population in future to prevent or to face the next pandemic once it happens in a more efficient way. Thank you, Dr. Thomas, for a nice presentation. Over to you.
Thank you, Vijay Kumar sir. Thank you, Thomas sir, for an enlightening talk on metabolic complications in COVID. Now, moving on to the third session, I invite our chairperson, Dr. Alexander K. George, to the dais. He's a consultant physician at Holy Cross Hospital, Kottayam. He's the president of API Kerala chapter. He's a man of great skill and compassion, and is a highly resourceful person. Sir, I invite you to this platform to kindly introduce the topic as well as the speaker for the next session. Over to you, sir.
Thank you very much, Asha. Good morning, everybody. I once again welcome you all on behalf of API Kerala chapter. COVID-19 is a unique virus with incompletely discovered pathophysiology, as we were seeing just now. We are seeing only the tip of the COVID-19 iceberg. Hence, it needs close monitoring of the symptoms and lab parameters and other things to go deep into this iceberg and expose that. It causes significant cytopenia, especially lymphocytopenia, excessive exhaustion of CD8 plus T cells, resulting in immunocompromised state and cytokine storm. This session, we are going to discuss the hematological manifestations of COVID-19 infection. To lead this discussion, we are fortunate to have Professor Dr. M. Joseph John with us. He is a very popular hematologist, expert, also an expert in this field. He is working as the professor and head of the Department of Clinical Hematology and Hemato-Oncology and Bone Marrow Transplant Unit of CMC Ludhiana, Punjab. He did his MBBS and MD from CMC Ludhiana itself. Later, he had his DM from CMC Vellore. After that, he joined CMC Ludhiana and set up the Department of Hematology and Stem Cell Transplant Unit in Punjab at CMC Ludhiana. Currently, the center has an active sibling and matched unrelated donor transplant programs for thalassemia and other hematological manifestations. That department is very popular. We are lucky to get the HOD of that department to discuss this important topic of hematological manifestations of COVID-19. Hence, I don't want to take away much of his time. Once again, I welcome you, sir, Professor Dr. Joseph John, and humbly request to start the session on hematological manifestations of COVID-19. Over to you, sir, Professor Joseph John.
Thank you, sir, for your kind introduction, and thank you, Dr. Sunil, for inviting me. And it was more of a learning for me as well as I am preparing and attending the session. So the task on me is to talk about what does the blood undergo during the COVID-19 infection. And it is actually enmeshed with all the other systems that Dr. Mary and Dr. Thomas has alluded to. A lot of things act with the coherence and interplay of things and the multifactorial things, and we are still grappling to find exactly what variable actually determines through a regression model. If you do a PubMed site search and put the words COVID and hematological, you would see this and a intersection of 393 articles on hematological manifestations. From there, if you move on, and if you look at all the hematological manifestations, if you have to just enumerate, these are the ones which happens in the blood. You can have the increased TLC or increased WBC, neutrophils for to be precise, mild thrombocytopenia, increased CRP, bilirubin, AST, ALT marginally elevated. I'm not going through these biomarkers, but we will stick to the hematological markers mostly. And we will concentrate on the etiology and the manifestations and what we can interpret and intervene with regard to lymphopenia, impact on CD4, CD8, high neutrophil lymphocyte ratio, hypercoagulability, impact of vaccine on the coagulability, impact of the blood group, and a bit of evidence onto which what we are trading in this last 2 years. Pathophysiology, if you look at from the chronological order, we are looking at the entry of the virus into the blood and going straight towards our ACE2 receptor and this receptor called TMPRSS2. And subsequently, it releases its RNA, multiplies, and what they call is a pyroptosis and release the damage associated molecular pattern or DAMPs, including the ATP and nucleic acids and oligomers. This is exactly what happens, and we all understand the spike protein, the spike antibody, we neutralizing antibody, the vaccine is of the spike. Those are, we are aware of it, and the ACE receptor onto which it attacks. And it has a direct effect on the cell. It dysregulates the renin-angiotensin activation system as well, and causing the tissue injury, inflammation, vasoconstriction, and vascular permeability. Now, I want you to contrast this in your mind, at least as of now, how the dengue fever attacks. The virus comes in, it has a different mode of attack, but there it is vascular permeability, which is much more under capillary leak we sort of talk about. In this situation, what we see is essentially a release of the pro-inflammatory cytokines and chemokines, and predominantly IL-6, IP-10, and macrophage inflammatory protein 1 alpha. Now, these are from the macrophages which are actually recruited at the time of infection. So this is what goes awry there in terms of causing the cytokine storm. I'll come to that a little later. So they attract even more monocytes, macrophages, and the T cells at the site of infection and produce this interferon gamma and establish a feedback loop. If it is a healthy patient and a healthy immune response, it attracts the virus-specific T cells to the site of infection, knock off the virus at the site itself. Or if we had already produced the antibodies, the neutralizing antibodies through a prior exposure or a vaccination, it will again cause an ADCC mechanism, antibody-dependent cytotoxicity there. So there will be minimal inflammation, lung damage, and these are the patients who have minimum symptoms or mild or no symptoms at all. So their T cells are robust there. There are neutralizing antibodies available. However, if it is a defective immune system, they accumulate further immune cells through the cytokines, and pro-inflammatory cytokines are formed and multi-organ damage. Now we basket all of this into the cytokine storm, and hence we think of bringing in steroids, tocilizumab, and other anti-inflammatory drugs to cause this overproduction of that. If you can think for a while, this is exactly what happens in a cytokine storm when we give CAR T cells, or for that matter, think HLH, hemophagocytic lymphohistiocytosis, overdoing of things of the immune system, causing further feedback loop of inflammatory markers and recruiting of more cells. So lymphopenia, I'll come to that analogy later. lymphocytes have ACE2 receptor. So that's the reason why it can enter the lymphocytes. It kills the lymphocyte. As of now, we understand that CD4 and CD8 cells are low, and this is a meta-analysis which was recently published based on where 13 studies they put in and said for sure the CD4 counts come down as compared to non-severe to severe. So the severe cells, the severe patients would get reduction of the T cells there. Same happens with CD8. However, if you look at the ratio, the cumulative, the diamond of the summary estimate shows that there is not much of difference there when it comes to the ratio. Now, what do we understand and mean by this? It is still early to say, although we allude that as a rationale, the premise to the mucormycosis predisposition. We do not have much of evidence on what happens in COVID in HIV. By and large, the WHO guidelines or WHO websites talk about probably an increased predisposition. But what happens to their CD4, CD8 ratio, we do not know. However, the risk of COVID has been noted to be more on patients who have a low CD4 count and not on antiretroviral therapy. I did a search in the PubMed. These terms were used: COVID, CD4, CD8, and mucor. Right now, it is only postulation saying that the reduced CD4, CD8 may predispose, but we do not have any solid evidence to talk about. But they also talk about various risk factors, which Dr. Mary also talked about, in diabetes and steroids and tocilizumab, etc., and prior lung conditions. We also see that there is some mild neutrophilia. If you look at the CBC of every patient of a COVID patient, you would see that there is a mild neutrophilia, and it is a likely response to a cytokine storm. And normally we have a neutrophil to lymphocyte ratio about 1 to 3. However, in these situations, it might go up to 5.5. And some studies have shown that if the neutrophil lymphocyte ratio is more than 3, they have a poor prognosis. Now, how much of that we can use it at the bedside is you need to see. We're not obviously going to tell the family the neutrophils are high and hence the prognosis is going to be poor. They've also noted a lower percentage of monocytes, eosinophils, could be because of the recruitment into the tissues. Mild thrombocytopenia and few cases of HLH. In contrast to in dengue fever, you would see a much higher percentage of HLH there. Now, the biggest villain among the hematological problems is the hypercoagulability. Dr. Vijay Kumar talked about one patient's finger toe getting gangrenous, and that has been seen by Dr. Mary as well here in many patients here. So 2 words to take home is immunothrombosis and thromboinflammation. These terminologies are being evolved similar to COVID-associated coagulopathy. That is another word called CAC, or now the immunothrombosis and thromboinflammation. So we understand Virchow's triad, that endothelial injury, then stasis and hypercoagulability. So endothelial injury tops the card here. There is a mild hypercoagulable state because of the inflammatory process, and there is a stasis if the patient is not moving much. So these endothelial damages cause these decreased fibrinolysis and increased thrombin production. And of course, if you look back at DIC, you would see the same thing, similar thing. But what is it different from DIC and the coagulopathy here? DIC, you would see both thrombosis and bleeding. Here you would see predominantly thrombosis and less of bleeding. There is no schistocytes. Even though there is microvascular thrombosis, which is mentioned, it is conspicuous by its absence of not having schistocytes in the peripheral blood, even though the thrombocytopenia is there, about 1 lakh or so. So That is the interplay of now thrombotic and inflammatory process which is happening. Various terminologies by various authors in Nature, and Nature was giving this good picture, so I could put it there: thrombocytopathy and endotheliopathy. Now, one interesting concept which we must understand about nets. Neutrophil extracellular traps are increasingly becoming very important in the understanding of thromboinflammatory process or thrombosis. Unlike we knew the phagocytic property only of neutrophils, it has also got a net effect, which is a neutrophil extracellular traps, where it extends its DNA out and it activates the factor VIII and the von Willebrand's factor to recruit more platelets and histones and trigger off a thrombotic process. So nets are increasingly becoming important in the understanding of DIC as well. Now that's the word I used, the CAC. It is a classical combination of elevated PT and APTT. If the APTT is prolonged, there is a 91, I mean, only a few studies here and there, mostly from Japan and China, most of the studies. APTT is prolonged, there could be a 91% chance that it could be LA. So from a clinician's point of view, when you get a PT and APTT deranged, what you need to ask the laboratory is to do a half patient, half control. If the half patient, half control is not correcting, it is likely that it is an inhibitor and then it is a lupus anticoagulant. D-dimers are positive. Of course, many of us monitor the D-dimer in terms of looking at the severity. And DIC was seen in patients who died. 70% of the patients who died had evidence of DIC. Pulmonary embolism is seen in about 30%. Elevated D-dimer in 66% and thrombotic events. So obviously, the interplay of COVID with the coagulation system is pretty high. And we are still deciphering the exact mechanism. There are many attributes to that. We can look at it right now. It has been also shown that the common DIC prognostic significance scoring can be used and predict the presence or absence of DIC. We also understand about CRP, LDH, and ferritin. There was some discussion on the ferritin being mentioned. Ferritin is an inflammatory marker. We were using that in the events of in dengue fever, and also we use that in HLH to use a diagnostic criteria and also to look at it under dilution. So CRP and ferritin going up have been correlated with pro-inflammatory markers. Now, whether this ferritin directly plays a role in mucor to be developing, yet to be seen. So there was a question on, can we give oral iron and will it hamper the situation? The answer is we really don't know the answer there. Should we give iron chelators? No, the answer is no, because iron chelators can even cause problems. From the thalassemia studies, we understand that if you give iron chelators while the patient is undergoing an immunosuppression, there could be problems. So it is a plus minus situation. Right now, we know that it goes up. Whether it has any implication in interfering with the treatment decision, we do not know. So there is a convergence and divergence from CRS and HLH. So this is an important way to understand things when we look at a cytokine storm. And we see this, as I said, macrophage activating system, activation syndrome or HLH, when there is an excessive activation of the T cells, which is now continuously being prompted and triggered off by the macrophages. And then the T lymphocytes become the villain there, causing to release a lot of these cytokines and causing various issues. We see this with cytokine release syndrome. The CART therapy, which is used in nowadays, is a T cell activation. So we understand that there is something to do with the T cells there. T cell is getting activated there, even though the C4 and the CD4 and the CD8 cells counts are low. The ratio becomes normal, but whatever certain the immune cells are triggering off what is being produced by the T cells. However, if you look at the similarity between HLH and the COVID cytokine storm, there is no splenomegaly. We are not seeing splenomegaly in patients with COVID. In fact, some of the patients have regression of the spleen size, no hypofibrinogenemia. I have some case reports of some of the patients with relapsed refractory Hodgkin's disease spontaneously remitting post-COVID. There are some patients, CLL patients, spontaneously the B cells are coming down. We really don't know whether we can make any associations there, but these are observations which may give us some kind of an understanding into it. When this happens in COVID, there are various other pathways getting activated, which is the renin-angiotensin pathway, because obviously there is a ACE2 receptor attribute to that, and JAK-STAT pathways. That's why a drug called ruxolitinib, which is a Jakavi, or inhibiting the JAK2 pathway, could be attempted. In fact, there were some studies to use this when the immune system goes up. There is some similarity for this in graft versus host disease as well. Again, the villain there is the T cell. Some sort of an inflammatory process is triggered off, and the JAK-STAT pathway gets activated there. There are some studies to say that, okay, if the D dimers are high, PT is deranged or combined, or if there is lymphopenia, profound lymphopenia, the chances of that you can predict it for a poor prognosis. There are some studies on the impact of the blood group on COVID. So this is early 2020. There is a 1980 patients. The NEJM published saying that if you have a blood group A, the chances that the risk of COVID-related infection and the complications are much more. And they've shown it with classic examples, saying that O is protective, A is a problem. And there was a subsequent study coming up in the Annals of Medicine saying that O is protective, lower risk, O group and Rh negative groups have less, and huge number of patients included. One of the rationales which I mentioned was that O group patients have less von Willebrand's antigen in their body, and that's a known fact. And so when you have a less von Willebrand's antigen, the chances of clotting comes down, and therefore microthromboembolism and macrothrombosis are less. It's very interesting how the science progresses, and we are to be adaptive and flexible in our understanding. And in April 7, this time researchers debunked the COVID link of blood group. That is because from the US, they did a socio-demographic study on a prospective study. The other way, retrospective study. There was not much of control in the population they included. And here they said it is unlikely that ABO blood groups have enough. Just to show you that what we believe very staunchly at some point are debunked subsequently. This becomes a major interventional thinking process which we need to do, how to anticoagulate these patients who have micro and macrothrombi. So if you look at, there are various COVID states, I would call, who can be on no medication before they get COVID, who could be on an aspirin or a clopidogrel when they get COVID, who could be on an oral anticoagulation while they got COVID, or they were on aspirin and oral anticoagulation while they got COVID. The COVID got tested, COVID is negative, happy situation, go home, continue the medication. COVID is positive, mild symptoms, continue the medications, go home, no changes. This is where we need to make a decision. Moderate symptoms, severe symptoms, prior states are these. How do we now handle them while the patient is in front of you? Moderate symptoms with oxygen, severe symptoms with BiPAP or on a ventilator. Now, the whole world has been thinking about it, and when we get, we have to see that there is a transition, can be from the moderate to severe. They can recover and go home, or they can die. We understand the extent of thromboembolism which happens in COVID infection, and that varies from 14 to 40% to be precise. I wouldn't go into the numbers, but we know that non-COVID hospitalized patients also develop VT. So it's an attributable, it's an additive risk of somebody who, anyway, a sick patient in ICU would develop thrombosis. And we were inclined to give anticoagulation in those setups as well. Now a COVID patient is now on a bed, we must give it. The question is whether I must give therapeutic dose, whether I must give intermediate dose, or whether I should give high dose. Should I combine it with aspirin or not to combine with aspirin? Should I give NOAX or should I not give NOAX? Now, these are the questions which are vexing in all of us. And when the choice is more, the decision making is even tougher. So these are our choices we have. Let's for a moment remove these options out. These come into play only after demonstrating a thrombus. After demonstrating a thrombus, essentially the algorithm of thinking and application and execution is the same like everybody else. It's a question of how to prophylaxis them. When you choose them, we need to talk about, and a trade-off is between the recent history of bleeding, underlying bleeding disorder, recent history of thrombosis other than the current problem, obese, non-obese, create clearance, OACs or aspirin already on or not, other comorbidities. So a multitude of thought processes have to go at the bedside before we can prescribe whether to give low dose, low molecular weight, intermediate or a high dose, should I combine with anything else. If you dig into the data, and that's a very interesting part there. There is data whether we should do, how often should you do D-dimer? How often should you do CT scan? How often should you send CRP? No answers to that in most setups. But there is a whole lot of algorithms which have come in for various reasons. These to show that this yellow is no data, and there is data only now to say that in a moderately ill on oxygen therapy, you must give low molecular heparin. Even in a critical ill patient, you must give it. But the question is whether to give therapeutic or not therapeutic. The data is conflicting. Various trials are underway. More than 60 trials are now ongoing across the world doing that. We have been part of an ASCO trial, which is looking at the anticoagulation possibility and the protocols to be used. A few interim analyses have come out. And so to speak, there is insufficient data to support anticoagulation to mild symptoms. So that is a proven thing. If you have a mild symptom, do not give it. Now the only debate is if it is a moderate or a severe, should I give prophylactic dose or should I give therapeutic dose? So the answer is out now partially to say that if it is a patient with moderate symptoms, therapeutic dose of anticoagulation helps. And if it is a severe patient, therapeutic dose does not help. Now the question comes, what happens if I started a therapeutic dose for a moderately ill patient and he becomes severe now? Should I stop? The answer is no. So that has come from the Rehab cap study. And recently, 2 more studies have come out on aspirin and use of DOAX after the low molecular weight heparin till 30 days. So those 2 answers are out. Aspirin has not added any benefit with 1 trial. Of course, there are many trials which are ongoing. So only the meta-analysis will give us the answers for that. The reason for removing the therapeutic dose from the severely ill was because of increased bleeding complications, and there is not much difference in the thrombotic age. So therapeutic anticoagulation has been shown futile in severe setup. So if the patient is on a ventilator requiring intubated and on a ventilator, do not start therapeutic dose. That's the answer. Now, often till now, we were saying that anticoagulation should be given only to those patients while they are in the hospital, not at home. And but there are, in practice, many have been giving. It's only 1 study which is came from, that is just 2 weeks ago, published from ASH, American study, showing that the 90-day outcome, 4.6% of 4.8 patients died, and because of venous thromboembolism and arterial thromboembolism within the 90 days of post-COVID. We've been hearing about the stories of people dropping dead because of post-COVID situation. We really don't know the answer there. As of now, the guidelines across the world say do not give anticoagulation, antiplatelet post-discharge unless they are documented, not for prophylaxis. Documented is a different matter. So that's, I put that there, saying that there is ambiguity in post-discharge anticoagulation there. Now comes the vaccine-induced thrombotic thrombocytopenia, which got a lot of media coverage, especially when the AstraZeneca vaccines had shown some amount of thrombosis. It is a reality, but it is a very rare reality, and it can happen somewhere between 5 to 30 days. Patients presenting with thrombocytopenia or thrombosis, then only you should suspect. No need to do all of this test, but if they come with thrombocytopenia or a clotting, ask for the D-dimer, screen for Doppler, screen a Doppler with for thrombus, and look for the antibody to PF4. The management essentially IVIG, steroids, continuation of the anticoagulant, non-heparin based. We can use NOACs, you can use fondaparinux. Plasma exchange, if it is severe and the platelets less than 30, this is between the devil and the deep sea situation where platelets are low, we need to give anticoagulation. What do you do? No, so there is, you can have a VIT, not a VITT, without thrombosis. Again, the treatment is again balancing, no definite answer. I would conclude with the last few slides on a paper which came out on June 2nd on low value medical care in the pandemic. Is this what the doctor ordered? Please read it if you can sometime. Now, if you look at some of the prescriptions we get here, I'm not too sure what happens in Kerala. It has got about 10 drugs almost, okay, including vitamin E, vitamin D, azathioprine, doxycycline, ivermectin, hydroxychloroquine, vitamin C, N-acetylcysteine, and inhaled Dexa. Now, this is when you don't know, throw everything in, cast the net wide so that something will catch. April 21, favipiravir was the top-selling drug when major guidelines have actually said not to give it. Anticoagulants like rivaroxaban has been prescribed in outpatient setting with recommending in most setups. The action trial that's just published said it has no role. Diagnostic check batteries, so there is this COVID test packages. There is no role of doing routine Dopplers in patients or routine CT scans unless the patient is symptomatic. Patients are getting every 15 days CT scan, and then some GOOs are there, ground glassing capacities, and then we are struggling to find a meaning to that and a score being attributed, and then trying to see what else to be done. So on one side, we have an opportunity to look at the evidence and collect the data, which is tougher than treating patients. This is some of the papers, I mean, some of the sentences from that paper. If you can look at it, when the convalescent plasma, ivermectin, all of them have shown to have no benefit. However, how many studies do we require to say yes or no to an answer? Should we wait for more studies to come and wait for the systematic analysis, at least with 2 or more studies, to say that the meta-analysis shown that there is nothing? The answer is gray there, but it is for, that is where medicine becomes an art and not science alone. And he has attributed a few of the sentences as a lack of accountability and elitism among the non-evidence-based medicine. And we must make it as adaptive as possible, the guidelines, and disseminate the knowledge in a transparent manner. So at the end of the lecture on hematological parameters, I talked about lymphopenia. I talked about anticoagulation requirement. I talked about low molecular heparin, whether in a therapeutic dose or a intermediate dose. And we talked about viral-induced thrombocytopenia and thrombosis, and the interplay of the immune system and the thromboinflammation. Need for gathering more data. The only evidence right now is we must anticoagulate if the patient has moderate or severe, either at a prophylactic dose or an intermediate dose. Thank you.
Thank you very much, Dr. Joseph Ron. Thank you very much for your excellent presentation. Maybe there are a lot of questions waiting. One thing, one doubt about this. What about this antibody assay? Is there any significance, especially post-vaccination effect and post-infection status? Is there any study that has come out with this antibody test?
Yeah. So, see, look, right now, in terms of using that in clinical application, it has not been established, in my knowledge. When we do antibody assay, we must see that is it against the spike antibody, spike antigen, or is it against the capsular antigen? Earlier antibodies which were coming as a detection as a kit were coming against the capsular antigen. And if the patient had a vaccine, and all the vaccines are the spike antigen vaccines, and if you did the other vaccine antibody testing, it was coming negative. In the studies, if you look at Covaxin, for example, Covishield looked at the outcome measure was essentially the breakthrough infections which they had, and that was their endpoint. Whereas Covaxin, it was neutralizing antibodies. Now, it is a logical thing to do, I would say. If you could, suppose I got Covaxin and the trials had said that it was, based upon neutralizing antibody, they looked at the efficacy. Then it becomes logical for me to say that I must look for that in my body and see if my antibody has been produced. If not, should I revaccinate? Now, these are all, it's an opening a Pandora's box there. This is all I can say. I don't know about any current evidence using that in clinical practice. I mean, I'll be happy to hear from any of the ID people in this forum if they can throw more lights on it.
Actually, there's no role in doing the antibody test because firstly, it's not a standardized test. Secondly, look at the neutralizing antibodies. So that is the one that they say. And each one will produce a different kind of response. So you don't know whether, which is the cutoff points. There's nothing established as yet. So actually, there's no role of, even after getting vaccinated, to go and check your antibodies. There is absolutely no role. That is what I have learned.
Thank you. Thank you. Any further questions, please?
Dr. Joseph John, I had two questions. One is role of prophylactic anticoagulation. When will you institute? And whether which is better, prophylactic anticoagulation or therapeutic anticoagulation in a patient with the moderate COVID. Second is, we used to give a very high levels of D-dimer when we are discharging the patient in some of the patients. Will this patient needs anticoagulation in the post-COVID region? Second, if long, how long?
Yeah. So again, there is no clear-cut answer. First question, I have some answer based on some of the studies, Remap CAP studies. So basically, if I have to answer, it has to be based on some trial or some ongoing clinical studies, trials which are going on. To answer the first question, the interim analysis have shown that moderate COVID, we must give therapeutic anticoagulation as prophylaxis. These are all prophylaxis in therapeutic dose or prophylactic dose or intermediate dose. That's the word. I mean, that's a classification in our mind. So in moderate COVID, we must give therapeutic dose anticoagulant. Now, that is from one study, but there are ongoing trials which are going on. So second question was, if the D-dimer is high, now D-dimer to be used as a positive predictive value with regard to, so we understand that the predictive value of D-dimer, right? It's a negative predictive value test. But to use that, now I had a few questions of patients who were post-COVID absolutely fine, D-dimer is 60,000. They did a CT scan, Doppler, everything is negative. Should you anticoagulate? Should you not anticoagulate? No scientific answer. Okay. So when there is no scientific answer, we use our art. You talk to the patient, comorbidities. No harm in inclining to say, I will give him aspirin for a few days, or I don't give, as long as there is no evidence to that. But if you look at the evidence, there is no evidence. But when I say that absence of evidence is not evidence of absence, that's the counter to that argument which we always make.
I have a question.
Yes.
Regarding the foot ulcer patients whom you have alluded also, I have described two patients with suddenly developing toe ulcers and both toe gangrene. Both these patients had normal ankle brachial index up to the level of dorsalis pedis, normal circulation, even after the gangrene has developed. So I am empirically believing that it is because of the coagulation, clotting of the smaller vessels supplying the toes, which has produced the gangrene. How can I assure? What investigation do you suggest, and what treatment regarding anticoagulation should I follow for that patient?
So here it is an arterial clot.
Yes.
And the immediate situation of an arterial clot, low molecular heparin would be the treatment of choice. And once it is over, we can follow up with aspirin, would be a reasonable option, because antiplatelet is what is helpful in an arterial clot. One, doing a PT, APTT would be a reasonable test to be done, because, and then if the APTT is prolonged, look at the half patient, half control. This patient may very well be lupus anticoagulant. Now, some of Dr. Mary, I'll ask Dr. Mary to share her experience about lupus anticoagulant being positive in a patient post COVID. Now, the principle is the same. Anticoagulate, if there is gangrene, it has to be removed, because whenever there is gangrene, it has to be removed, and follow up with anticoagulation. Now, if you ask me point blank how long, I do not have an answer to that. But as long as the lupus anticoagulant is positive, and we assume that if it is a lupus anticoagulant positive, it will be a longer duration of treatment, continue that. Dr. Mary can probably share some of her experience with the lupus-like situation in COVID.
So we had one patient early last year who had presented like with COVID nose and toes, it's known to cause this pseudo frostbite-like picture. And this lady actually was just COVID positive. She was not at all symptomatic for COVID, and she had actually TB also coinciding. She was just a mild COVID. But earlier we used to admit all the patients with COVID. So on maybe the 6th or 7th day, she suddenly started developing pain in the fingertips and at the tip of the nose. We started noticing blueness of the ears and even the toes, and even on the thighs and all, there were bluish areas. So we investigated her at that point, and we found that the lupus anticoagulant was negative on her. And we had to actually just wait. We started anticoagulation, but we had to wait for her gangrene to settle. In fact, she lost a limb, eventually, her hand, because of COVID. And this was the first case that I've seen that was the early COVID times that we had such a severe COVID, severe loss of limb with gangrene with loss of limb. Second, 2-3 patients we've had femoral line thrombosis, even arterial, the neck, even line thrombosis is common. We had to take one lady in for removing the clot. It was all over the femoral artery, the popliteal artery, and the leg had started turning blue. Now, this increased thrombosis, I think, we did not send an lupus anticoagulant on her, because unfortunately she died. So what I have seen, I've had 3 patients, one on whom I sent lupus anticoagulant was negative, but the other 2 I have not sent. So this is my experience. It causes severe gangrene. The initial one, this time I'm not seeing so much of peripheral gangrene. More of a lung. We are having a lot of lung alveolar ventilation problems with possibly some microthrombi in the pulmonary vessels, leading to this thromboinflammation. Actually, they have a thromboinflammation in the lung. That is the pathogenesis of this severe hypoxemia that they develop. Post-COVID, virus, the first stage is the viral stage. After that, you have the pulmonary phase. And here is it with hypoxia, without hypoxia. So when it comes to with hypoxia, usually the thromboinflammation has started. The third phase has started. And there we see increasing CRPs and D-dimers going up, So, I mean, this is just a clinical, I haven't looked into the literature, haven't had the time actually with the load. But I don't know, Joseph, if you would agree with this.
Dr. Joseph John, suppose if the patient is on aspirin and the patient has gone to the severe state, will you ask the patient to continue with the aspirin, or you have to stop temporarily?
No, absolutely. Continue with aspirin.
Continue with aspirin.
Continue with aspirin. In fact, continue with aspirin and probably low dose anticoagulation to be continued. Prophylactic.
So what is this low dose? And can you tell
Low
us
dose
the
is prophylaxis. Prophylaxis.
prophylaxis?
There are 3 doses we need to consider as prophylaxis, intermediate dose, and therapeutic dose, which is 1 milligram per kg once a day is your prophylactic dose. 1 milligram per kg twice a day is your therapeutic dose. Anything in between is your intermediate.
One question. What about thrombolytic therapy if it is indicated?
Please go ahead. We must do that. If there is a thrombosis which is established. See, established thrombosis would take the pathway of our existing knowledge. Go ahead and do everything required for that.
Any more questions?
Yes, so we have a few questions. So Dr. Tommy has asked that some French studies showed that the patients using Metformin or sitagliptin for diabetes have lower level of inflammatory markers and with less complications, provided their blood sugars are controlled. Could you please comment on that?
Dr. Thomas, that question is to you. I am not equipped to answer that question. Is Thomas around?
Yeah, and actually, yeah, it's a good question. But the metformin in mild COVID, we have information that it is good. Progression also, there is 2 studies. About DPP-4 inhibitor, yes, even the previous flu, it was like that. It was like the previous flu, it was informative. But there is a small risk of increased risk of pancreatitis in people who are using DPP-4 inhibitor in this setting along with glucocorticoid. Otherwise, it was proved to be beneficial in a couple of studies.
Thank you, sir. Sir, there's another question regarding the contraindication of Covishield if the patient is an ITP patient.
No contraindication. Both can be given across the board.
Okay, sir. And sir, various.
Yes, Dr. Rasha, you complete.
Yeah,
I will take up then the YouTube questions.
Okay, sure. The other questions are basically regarding the prophylaxis criteria and also the discharge on anticoagulation. I think, sir, you have elaborated on that already. Yeah. And the other question is, what about the relationship between vaccine and thromboembolism? And different studies are showing various results. Could you please give a clarity of the question, sir?
Yeah, so I think I addressed that. But anyway, there is the incidence is very little, and all the major guidelines in the forums, societies have come forth and said the risk versus benefit, giving the vaccine is better off than not giving the vaccine. So go ahead and get it. No need to follow up. If there is any symptoms, then only to be checked for.
Sir, one more question. That is, there are many patients who are not doing RT-PCR, but are sure that they have contracted mild COVID at least. And in such group, is there a usefulness for the antibody test to decide whether to vaccinate or not?
No, no. Go ahead and do. Even if you've got a frank and severe COVID, you must vaccinate.
Yes. And sir, about anticoagulation in pregnancy, sir.
Anticoagulation in pregnancy, the rule follows the way we normally follows in pregnancy, which means if it is the first 3 trimesters, we would give only low molecular heparin and then continue. Otherwise, no changes there.
So there's also a question on the discharge criteria for moderate COVID in pregnancy, especially on the anticoagulation aspect.
At discharge, no anticoagulation unless they had a documented thrombosis during the hospitalization.
Okay, sure, sir. Thank you. And I think we are done with the questions in our chat box. Maybe from the YouTube, we can have some questions.
Yeah, YouTube, we have around 4 or 5 questions. First question is for Dr. Thomas Paul, sir. So why there is a hypotension in non-hypertensive during COVID, and does the continuation of hypotensive state cause any problem in future?
Your question is, if I agree, if you understand, it is a hypotension during post-COVID. Is it like that? Is it a question?
Yes, sir, hypotension, sir. Hypotension.
Hypo or hyper? Hypo,
sir. Hypotension.
Hypo, yeah. So this is once again related to the vasodilators mediated one, and also it is there are the renin aldosterone that axis also employed in some group of patients where they were previously hypertensive and going through hypotensive phase during COVID and after COVID. So these are the two postulates, but none has been proved. That is this is my update only up to April. I've not got it updated in May and June. So others also can tell.
So next question is for John, sir. So first question is, sir, how many patients on post-COVID recovery on follow-up showing severe leukopenia with neutropenia?
I don't have that number. Post-COVID recovery or persistence of leukopenia, I do not have the data. I'm sorry.
Okay, sir. So one more question is there. So can you throw some light on how to manage a dengue fever with thrombocytopenia patient having moderate to severe COVID?
Okay, so that's a double-edged question, which has got double-barreled question, which has now 2-3 aspects to it. Dengue and COVID co-infection is what you're saying. Okay. So
Yes,
the
sir.
principle would be prioritization of the symptoms and which takes precedence of the other. If the platelets are absolutely low, less than 30, no anticoagulation. If the platelets are more than 30 and the patient has preponderance and comorbidities towards a moderate COVID situation, anticoagulants may have to be given with platelet transfusion. That would be the ideal situation. But again, it has to be taken on a case-to-case basis with the history of other negative effects which can happen, adverse effects which can happen by anticoagulation. But rule of thumb is minimum 30 is required.
Joseph, can I just add to this?
Yeah, sure.
Last year, we had actually quite a few patients who were having COVID as well as dengue, in the time. And what we were doing, the moderate ones, mild ones, we never used steroids. But somehow the steroids helped when we used the moderate. We didn't have to give any platelets extra, So the steroids, it's like an immune thrombocytopenia possibly. It just helped. This also causes an HLH-like picture, right?
Yeah.
Increased ferritin in both. In fact, the ferritin levels are much higher in dengue patients, we've observed, compared to that of COVID. So we would say suddenly the ferritin levels went up, because we just tested that because we are currently doing a study on ferritin levels in dengue. So last year we had dengue as well as COVID double whammy together, and we never had to transfuse. Maybe just one patient I can remember offhand that we'd had to transfuse, but the steroids helped,
Okay, I think that time is out. Shall we conclude this session?
Sure.
So let me thank Dr. Joseph John once again for the nice presentation. On behalf of FPA Kerala State, I thank each and everyone. Thank you very much.
Thank you, sir.
Thank you, sir. I thank Joseph John, sir, and Alexander, sir. Now, moving on to the next session, I would like to invite our chairperson, Dr. Joyce Geo, ma'am, to the platform. She is Associate Professor in Pushpagiri Medical College in the Department of Psychiatry. She is a resilient personality with ample experience and deep knowledge in the field of psychiatry, with special interest in the field of women's health and adolescent psychiatry. With all due respect, I invite you, ma'am, onto the stage. Please introduce the topic for the next session and the speaker also. Over to you, ma'am.
Thank you, Dr. Harsha, for the introduction. At the outset, I would like to thank the organizers of the CME program, API Kerala chapter, Central Travancore Physicians Club and Department of Medicine, Pushpagiri Medical College, and Dr. Sunil for inviting me to chair the topic of post-COVID psychiatric complications. And we are facing a tsunami of psychiatric or emotional disturbances in post-COVID period. Experts say around 1/3 of patients, 1/3 of COVID recovered patients are having some emotional disturbances. And every day we are facing many patients suffering from anxiety disorders, panic symptoms, obsessive compulsive disorders, body anxiety, and somatic symptom disorders, and depressive disorders, and many more. So we have a renowned speaker on this topic, and it is my privilege to introduce Dr. Arun B. Nair, happened to be a good friend of mine, and Associate Professor, Medical College Trivandrum. He is a very well-known media person, and we consider, Indian Psychiatric Society Kerala chapter, we consider him as the brand ambassador of our Psychiatric Society. And he's a lot to say about his interest and his positions. He's author of 15 books, including Advances in Psychiatry and Medicine. And he had conducted around more than 1,000 episodes of health awareness programs in media. And he's the author of a section of mental health in Sarvarogya Vijnana Kosham, an encyclopedia of health in Malayalam. He wrote the chapter section of mental health. And he is guest faculty in Kerala Judicial Academy, High Court of Kerala, IMG Trivandrum, and State Institute of Health and Family Welfare. And he is a recipient of several awards, including IMA Media Award, and the list continues. Over to Dr. Arun for the topic of post-COVID psychiatric complication. Thank you.
Thank you, Joyce, Madam, for those extremely kind introductory words. My sincere gratitude to Association of Physicians of India, Central Travancore Physicians Club, and Department of Medicine, Medical College Pushpagiri, especially to Dr. Sunil Matthew, sir, for giving me this great opportunity to share the platform with some stalwarts in the field of medicine, hematology, infectious diseases, etc. I shall share my screen. Hope the slides are visible. The topic for my presentation is psychiatric problems in COVID-19. As it is mentioned, after every pandemic in the world, there has been a period of lot of emotional and psychological distress affecting all sections of the population, ranging from small children to the elderly. 100 years back, after the Spanish flu pandemic, we had the phase of Great Depression affecting all over the world, with large number of people developing depression, suicide, substance addiction, and whole lot of psychiatric problems. So a lot of psychiatric problems are seen in people who are affected by COVID, those who have recovered from COVID, and due to the COVID scenario and the consequent lockdown, a large section of the people who are unaffected by the COVID virus also are suffering from psychiatric problems. So the most important problem to begin with when the COVID pandemic struck for the first time was the stigma associated with COVID-19. We can recall a couple of instances in Kerala where healthcare workers were ostracized and stigmatized for working in COVID ward. A couple of male staff nurses working in Government Medical College Kottayam who had worked in the COVID ward had to vacate their rented house because the landlord did not take lightly the fact that they were seeing COVID patients. A person, a pediatrician who had returned from Gulf to Thrissur, he was locked inside his flat because the neighbors thought that he was COVID positive. And the term COVID was not yet popular at that time. So they had posted a sticker outside his house saying that this house has a corona patient. So that used to be the issues to begin with. And healthcare providers are more affected by the stigma than anyone else. Fear of isolation, racism, discrimination, and marginalization. All these issues are associated with COVID. The stigmatized community, which is ostracized, may seek treatment late. They are more likely to run into complications of COVID, and the delay in treatment seeking is a direct consequence of the stigma associated. And health crimes are also very much associated with COVID. So the psychiatric problems in COVID can be broadly divided into three categories. The psychiatric issues in the people who are COVID positive, affected by COVID and its complications. Problems in the society due to pandemic and lockdown. Primarily, those people who are not COVID positive are suffering from these. And of course, the third and the most important one, the post-COVID psychiatric problems. So coming to the psychiatric problems in people who are affected by COVID, the burden of isolation and quarantine. The protocols for quarantine and isolation are changing with every phase of the COVID. But when COVID had come to our part of the world first time, the first case in India was reported in Kerala. At that time, there was very strict action from the health workers. Everyone who was a primary contact of a COVID positive was isolated, had to undergo quarantine. So illness anxiety was a very important problem at that point of time, the initial phase of the phase 1 of COVID. Illness anxiety means a person fears that he has contracted a very severe illness. Even though he is negative, he feels that he has got the illness and he may die as a consequence of that illness, and he panics out of that. So there was the situation where if anybody in the neighborhood was coughing, certain people would get a fear that that person is COVID positive, and COVID virus may get transmitted through the air and reach us, and we may be infected and we may die. So a lot of distress associated with that. And there was also this mass hysteria phenomena about the COVID, and the social media and mainstream media added to the panic, which we shall discuss in subsequent slides. A large number of people who had to be under isolation and quarantine were suffering from irritability. They had a fear of spreading infection. There was significant anger, frustration, loneliness, sleep disturbance, which was universally present, depression, and suicide. I shall discuss half a dozen cases of prototypes of situations in which COVID has led to psychiatric problems in the subsequent slides. A paper which was published by Lancet in 2020 clearly showed that a large number of people were suffering from depressive symptoms and anxiety symptoms. Around 2/3 of the total population who were COVID positive were suffering from depressive symptoms, around 52% from anxiety symptoms, around 20% were suffering from anger and irritability, 18% suffering from anxiety symptoms, and around 10% suffering from guilt, whether they had led to spread of the infection in their own households, among their relatives, among their loved ones, and in the community at large. Around 1/3 of the people who are COVID positive were reported to have sleep disturbance. And quite a large number of people who were COVID positive or were primary contacts, at least 35% as per the statistics at that point of time, were suffering from obsessive compulsive disorder. Obsessive compulsive disorder is a condition in which you have got recurrent, intrusive, unpleasant thoughts, impulses, or images, which you yourself know is not very rational or logical, but you can't help it. You can't prevent it. And these thoughts lead to intense anxiety. And to overcome the anxiety, you resort to certain repetitive behaviors. The large number of people who had come to contact with people with COVID had these repetitive washing behaviors. They used to wash their hands repeatedly, even though the protocol used to say that wash your hands using soap for 20 seconds or sanitize it with a sanitizer. They used to repeatedly wash their hands over a long period of time, leading to full-fledged obsessive compulsive disorder. And certain people had this checking behavior also, checking whether their hands were contaminated, and even, repeatedly going for RT-PCR tests or antigen tests just to know whether they were COVID positive. And the influence of social media on the pandemic was also significant. The phenomena called the COVID infodemic, an avalanche of information was pouring in from various quarters. The mainstream media was telecasting programs on COVID. A large number of health professionals were featuring even in the evening discussions in TV channels, and the topic was COVID for a large period of time. Social media was also spreading panic. In the initial phase of the COVID, as we all know, when Italy was going through big trouble, a lot of videos were circulating about the situation in Italy where people were denied admission to hospitals. They had to lie down on the streets, without oxygen and difficulty in breathing and dying on the streets. And such kind of videos and messages were spreading significant panic among all sections of the society. And then came the news about magical remedies. All sorts of alternative medicine practitioners were mentioning about preventive medicines, therapeutic medicines, and whatnot for COVID. And that continues. I recollect one of the earliest videos which were circulating virally in social media in Kerala happened to be the video of a person preparing an alcoholic drink with a little bit of lime juice added to that and declaring very openly that if this is consumed 3 times a day, the coronavirus will never attack you. And significant hate content was also spread through the social media. There was a lot of hate speech and hate content spread regarding vaccination. When the vaccine was first introduced, there was a propaganda about vaccine, that vaccine can lead to infertility, sexual dysfunction, etc. And it is the part of a ploy by the Western world to annihilate a section of the society. Such kind of hate content with explicit communal touch was also spreading in the social media. So coming to the most important psychological problem seen in people with COVID-19, that happens to be depression. So the Brain Behavior Immunology journal in 2020, October, reported a study that 31% of adults surviving COVID developed depression. The British Lung Foundation and Asthma UK's post-COVID survey of over 1,000 patients, of which over 800 people had not been admitted to a hospital, found anxiety and depression in the top 5 reported symptoms of long COVID. Long COVID, I hope, was discussed in the previous talks. Change in mood involving anxiety or depression was reported in 22% of the people. And in India, a prevalent study in general population, which was published in the International Journal of Social Psychiatry, showed that 25% of the participants were moderate to extremely severely depressed. Studies about depression in healthcare professionals in India showed that depressive symptoms requiring further evaluation was seen in 11.4% of healthcare professionals. And women were reported to have approximately twice increased chance for developing depressive symptoms requiring treatment compared to men. And how do we identify depression in a person with COVID or in a person with any medical illness for that matter? As we all know, depression has got the following 9 symptoms: continuous sadness from morning till evening, reduced interest in previously pleasurable activities, unexplained tiredness, sleep disturbance, most probably an early morning awakening pattern, appetite disturbance, concentration impairment, slowness of thoughts and actions, or an increase in speed in adolescent age group and elderly. Depressive thoughts including hopelessness, helplessness, guilt, and worthlessness. And finally, once the person harbors strong beliefs of worthlessness, death wishes and suicidal ideas also are generated. Out of these 9 symptoms, if 5 of them are present for 2 weeks, that is a depressive episode or a major depressive disorder, as we call it. But unfortunately, from these lists, at least 4 of these symptoms are very commonly present in people who are suffering from medical illnesses. For example, a person who has got a significantly symptomatic COVID-19 infection is supposed to suffer from fatigue. Fatigue may be part of the physical illness itself. His sleep may be disturbed as a direct consequence of his physical problem. Appetite may be affected. Concentration also may be affected. Imagine the case of a diabetic person on insulin. Again, these 4 symptoms may be present. A cancer patient on chemotherapy, a transplant recipient on immunosuppressant drugs, or even a coronary artery patient with a stent recently inserted in situ. All these people can have fatigue, sleep disturbance, appetite disturbance, and concentration disturbance. So these 4 symptoms are not reliable symptoms to diagnose depression in a person with a medical illness. So what is the solution for that? We have got the Endicott's substitutive criteria. In this criteria, we substitute the previously mentioned 4 symptoms of depression. That is fatigue, sleep disturbance, appetite disturbance, and concentration disturbance with new 4 symptoms. person is brooding over something, remaining immersed in thought for a long period of time, is expressing pity repeatedly over one's condition, and is pessimistic about everything, including the treatment. This pessimism is a very important point, because pessimism about the treatment is an important factor, single important factor, which leads to non-adherence to treatment in any medical illness, especially chronic medical illnesses. And a withdrawn behavior. A person who used to have a lot of friends, used to be very socially active, an extrovert kind of a person, suddenly becomes withdrawn. He is not interested in talking to others, even through telephone or social media. He becomes withdrawn. He doesn't face even the visitors in his house, and finally, confines himself to his own room, becomes wheelchair bound or bedridden. Then a fearful or tearful facial expression may be seen. A fear, probably a fear of death, or what would happen to his near and dear ones after his death, may be prominent. Sometimes crying spells for no reason, no obvious immediate trigger, we should say. So there are certain conditions like Parkinsonism in which the facial expression may not be obvious because of mask-like faces may be clear, but there also tears can be present. And non-reactive mood, or an inability to be cheered up. In elderly people who are suffering from medical illnesses, this one is almost a telltale sign of depression. A grandpa or a grandma who does not show any emotional response even on seeing a grandchild is most likely to be depressed as per the cultural observations. So the next group of problems which are seen in COVID-19 affected patients is anxiety disorders. Different kinds of anxiety disorders are there. So adults surviving COVID-19, 28% of them had post-traumatic stress disorder. Post-traumatic stress disorder means if you have gone through a stressful event which has threatened your life or your existence or your identity, or you have witnessed some such an event, if you are admitted in the intensive care unit where a patient admitted in the next bed was showing significant breathing problems, and he died in the ICU after a traumatic experience, fight with COVID, and you were witnessing that event, that can also lead to this post-traumatic stress disorder. So immediately after the event, if a life-threatening COVID infection happens to oneself, or you have witnessed something like that in your relatives or in your neighborhood bed patient, you can have acute stress reaction. Your sleep may be disturbed. You may be having flashbacks about what has happened. And even days or weeks or months after recovery, you may have these symptoms again. So 3 important characteristic features of the post-traumatic stress disorder. Number 1 is flashback experiences of the traumatic event. So even when you're comfortable at your home, even after your COVID has been completely cured, you may get similar emotional experience of breathing trouble and distress which you had experienced while you were in the ICU. Next is nightmares. While trying to sleep, you may get nightmares about the distressing experiences, and you may wake up from sleep and you may be unable to complete your sleep. And third is you may avoid any kind of information, videos, audios, literature, newspaper cuttings, or even talk about COVID, because the word COVID itself triggers a lot of unpleasant memories, traumatic memories in you. So avoidance of anything which triggers a memory of your unpleasant experience. These are the 3 features of PTSD seen in 28% of the population. 31% of them have depression. 42% have got anxiety. Among anxiety disorders, the commonest one happens to be panic disorder. Panic disorder means the symptoms are very similar to a myocardial infarction. You sit comfortably at a place, there is no reason to feel anxious. Suddenly, your heart is pounding, you have palpitation, breathlessness, burning sensation in upper abdomen. You have blurring of your vision. You feel that you are about to fall down and die. You feel that you may lose your mind. You may become crazy. So these kind of intense anxiety attacks lasting for say 10 to 15 minutes, after which they die down gradually. It's very commonly seen in people with COVID and people who have recovered as well. 20% have got obsessive compulsive symptoms. And these obsessive compulsive symptoms are most commonly seen in younger population. I had a chance to see a couple of children who had COVID and had recovered from COVID. And after that, they had presented with significant obsessive compulsive symptoms. The first child, a 12-year-old boy, had presented with the classical washing, repeated washing kind of a presentation. And the second child, a 10-year-old girl, had presented with sudden onset of repeated checking behaviors, creating some abnormal sounds, including some abusive words being told at people, and sudden anger outbursts, throwing objects, assaulting others, which was very unlike her behavior before that. And in this case, it was a case of COVID. It was complicated by bacterial infection also. Probably she was administered antibiotics as well, and she had recovered following that. And we had the symptomatic presentation was very similar to something called the pediatric autoimmune neuropsychiatric disorder associated with streptococcus, the PANDAS. We had done an ASO titer, it was significantly high, and we had to put her on oral penicillin along with the drugs for obsessions and tics, and she responded well to that. She is now maintaining well on medicines still. So these kind of presentations are also very commonly seen. The British Lung Foundation and Asthma UK's post-COVID survey, which I have already mentioned, found that anxiety and depression was there in the top 5 reported symptoms of long COVID. Regarding the mood symptoms, some studies from the Georgia University recently have shown that long-term COVID infection, especially those who had to receive oxygen on long-term or needed ventilator support for long-term, had some problems with the gray matter. And this gray matter reduction was very commonly associated with sudden onset of depressive anxiety symptoms and irritability symptoms. So a prevalence study in the general population in India showed 28% of the population had, moderate to extremely severe anxiety, and 11.6% had moderate to severe stress. And in healthcare professionals in India, the high-level stress, which incapacitated them from working, was there in 3.7%, and anxiety symptoms requiring further evaluation was seen in 17.7%. Women, approximately, they had 2 times the increased chance of developing moderate to high-level stress or anxiety symptoms, just as in the case of depression. Another area which warrants a lot of attention is the psychiatric problems in children and adolescents in the COVID season. I'm not mentioning about children and adolescents affected by COVID. Children and adolescents who are supposed to sit at home and endure the problems of online education. The prevalence of attention deficit hyperactivity disorder has increased significantly after the onset of the pandemic. Most of the studies in 2019 period showed that the prevalence of ADHD was around 5 to 7% in school-going children. And recent studies have shown that it is increased to 10 to 12%. And physical inactivity, continuous exposure to screen, consequent behavioral addiction, etc., are leading to worsening of ADHD. The attention span of children is coming down. They are becoming more and more hyperactive and impulsive. Depression is commonly now seen as, especially among the adolescent population. Quite a large number of adolescents are presenting with attempted self-harm because they are incapable of communicating to their parents regarding their depression. And even if that is communicated, the parents would trivialize it and suggest some homemade remedies like listening to music or doing yoga or going for a walk and things like that. But once you are severely depressed, they don't work. And a large number of them presenting with attempted suicide. Panic disorder, I have already mentioned, very commonly seen in children and adolescents. A large number of children presenting with somatoform disorders or somatic symptom disorders as such. So this somatic symptom disorder means there are certain physical problems which are real or imaginary, but the concern and anxiety associated with them is out of proportion to the actual physical problem. So they feel that they are extremely tired, extremely weak, and they have low levels of energy. Sudden onset of dissociative problems are also seen, especially among adolescent females. Commonest presentation happens to be dissociative convulsions following immediate stress, some abnormal movements resembling seizures with a period of lack of awareness following that. But the EEG does not show any problems. Neurological examination and investigations does not show any problems. And the biggest problem which the parents are facing right now is the behavioral addiction in children. Large number of children are getting addicted to internet, online gaming addiction, social media addiction, porn addiction, and exploring dangerous terrains, including dating apps, and even the dark net is very common right now among adolescents. So coming to the impact of the pandemic on health workers, large number of health workers are suffering from burnout. Some studies have showed that as much as 50% of the healthcare professionals are suffering from mild to moderate levels of burnout. Vicarious traumatization, which you feel traumatized for something you have not witnessed directly, heard about, reported in your institution. 50% of healthcare professionals have mild depressive symptoms. 33% suffer from frank sleeplessness. 14% of the physicians and 16% of the nurses who are into COVID care have moderate or severe depression. The study published recently in Lancet about the post-COVID problems have shown that 34% of the people who have recovered from COVID have psychiatric problems in the next 6 months. 17% of them suffer from anxiety disorders, 15% more disorders including depression, 7% from substance use disorders, 5% from chronic insomnia, and 2.1% from ischemic stroke, 0.6% brain hemorrhage, and 0.7% have got cognitive impairment resembling dementia conditions. I shall just illustrate with a few cases. Miss X is a 45-year-old bank staff. During initial reports of COVID, she was a bit worried, but carried on with her work. She used mask and gloves, but on returning home and watching TV, she is disturbed by the news related to COVID. These thoughts go on for 30 minutes and then settles down. What is this? Is it a disorder? Is it a psychiatric problem? Obviously, most of us had similar problems during the initial phase of the pandemic, more so in Kerala, because we, the people of Kerala, had witnessed a Nipah infection a couple of times in the last 2 years. So we were a little bit petrified about the COVID, whether the mortality is as high as Nipah is something which we feared, even though the literature was pointing out otherwise. So most of us had these kind of concerns. It is actually a normal phenomena because this thought is there, but absolutely no impairment in the socio-occupational functioning. 45-year-old hospital attendant in a hospital which was not reported or treating COVID cases, but protective equipments are given. At home, he becomes angry for very silly reasons, keeps on checking mobile for the news on COVID. He's hesitant to go to work, but goes because the wife is persuading. So some level of impairment in his occupational functioning is there. This is called adjustment disorder. It's not a major psychiatric problem. With proper psychological intervention and proper social support, he can easily overcome that. A 42-year-old lady whose husband is in Dubai lost his job but unable to come back due to COVID. Elder daughter's marriage is fixed in May, but there are financial issues. She is sleepless, sad, not doing any household work for the last 3 weeks, and recently expressing death wishes. So now we know definite impairment in biological functions, definite impairment in socio-occupational functions, clear-cut sadness and death wishes. This is a case of major depressive disorder. She may need treatment with antidepressant medications. 40-year-old man working in a restaurant lost his job, started smoking heavily and using illicit liquor in large quantities. He resorted to assaulting his wife and children also. Definite impairment is there, that is substance use disorder. He may need an address treatment for substance use disorder, as well as an evaluation for any underlying psychopathology, including anxiety or depression, and treatment for that. 24-year-old lady, after seeing news about COVID in TV, is feeling breathless intermittently, feeling chest pain, checks the temperature frequently, and asks the mother whether she is having COVID. So we know there's an excessive anxiety about an illness, and that is nothing but the illness anxiety disorder. A 35-year-old blank employee, after returning home, repeatedly washes his hands as well as the objects he touches, including the newspaper. He's washing even the newspaper in Dettol before he touches it. And as a result, the newspaper just vanishes, becomes unreadable. This is a case of obsessive compulsive disorder. This also needs treatment with medicines and psychotherapy. So regarding the mental health issues during lockdown, pre-existing psychiatric disorders were there, which got exacerbated because many people were afraid to go to hospitals and seek treatment. Despite the facilities like district mental health programs supplying medicines, many people were afraid of going out of the home, and that led to poor drug compliance and exacerbation of pre-existing conditions and new onset mental health problems also. Commonest new onset problems included health anxiety, depression, numbness, irritability, boredom, anger, insomnia, substance withdrawal, acute stress reaction, end of the life crisis, which was very commonly seen in elderly people. A 75-year-old person, a prominent literary figure, he was asking me last week, Arun, this pandemic has not ending. There is absolutely no idea regarding when it is going to end. I am going out. I want to go out and enjoy my life. Even if I die, it's okay because I have led a full life. I don't want to sit at home like I have been doing for the last 1 year. This kind of issues are there. And pre-existing illness is also exacerbated. Stopping medicines was an important problem. Drug interactions were also. So many people who developed mild COVID, who were on long-term treatment with psychiatric medications, stopped medicines on their own without consulting their psychiatrist, and they worsened. And of course, we had drug-induced behavioral problems also. Steroids are being used, and steroid, as we all know, can lead to psychosis in vulnerable people, mania in certain other sections, and depression in a third group of people. Some people who had developed the neurological complications of COVID developed seizures, and some of them were put on levetiracetam, and those people who were put on high-dose levetiracetam also developed psychosis, depression, and mania. Drug-induced issues, but of course, if such a drug is mandatory, that has to be continued, and we have to give appropriate treatment for the drug-induced behavioral problem, because steroid cannot be done away with just because it produces some behavioral problems. So in children, again, the fear about the illness, the hyperactivity, and behavioral addictions. Then how to help? Telecounseling is widely present, and that is definitely the practical option. So we have to follow all the guidelines of teleconsultation, which have been put forward by the Medical Council, including which all medicines can be prescribed and which cannot. I'm not going to the details for want of time. Psychological first aid is something which we have to teach all the people, because the 5 steps: approach a person in distress, listen to him, give information, encourage professional help, and encourage social support. These have to be taught to everyone so that adequate support can be given at home itself. Psychological support for children using helplines, district mental health program services providing medicines to those people who are on chronic treatment, and the art of remaining engaged, exploring one's creativity, and remaining physically and mentally active. These are the ways to counter the psychological problems in COVID. Thank you very much for your extremely patient listening.
Thank you, Dr. Arun. It was a great presentation, putting us in various scenarios of life post-COVID. And now the topic is open for discussion.
Dr. Arun, one question I want to ask you. There are some patients who are working in our hospital. They're post-COVID patients. And they used to come to me with the symptoms suggestive of not interested in the work, and they are feeling easy fatigability, and they are looks depressed, and they have got a lack of sleep, and everything is there. And when I told them to go to the psychiatrist, especially Joyce madam, they are hesitant to go there because they will be branded as a psychiatric patient. So in that type of situation, what type of medicines which I can give them as a physician?
Okay. So it depends upon the symptomatology with which they present. If it is prominent physical symptoms, especially a post-menopausal lady is presenting with a lot of physical symptoms, vasomotor symptoms, etc. Along with that, there is sleep disturbance and anxiety. An SNRI, a serotonin norepinephrine reuptake inhibitor like desvenlafaxine, and a low dose of clonazepam for the initial anxiety can be prescribed. The clonazepam may have to be tapered and stopped because benzodiazepines are the only medicines which produce a dependence potential in psychiatry. But if the patients are presenting with only the cognitive symptoms of depression or anxiety, the physical condition, the energy level is reasonably okay, but they are feeling sad, they are contemplating suicide, and they are feeling hopeless and all that. SSRIs, selective serotonin reuptake inhibitors. And we have to take into account the drug interactions if the person is already on any medicines, especially they are on beta blockers or antihypertensives, diabetic drugs, etc. In most cases, drugs like escitalopram and sertraline have got minimal drug interactions. The CYP drug interaction potential is less with these two. They are preferred. But of course, if they have got gastritis, as we all know, gastritis is one of the very common post-COVID manifestations, the gastroesophageal reflux and things like that. If the gastritis is intolerable, SSRIs and SNRIs may be intolerable. In such cases, for prominent gastric symptoms, if they are present, drugs like mirtazapine, which is a noradrenergic and specific serotonin can be given. Or if they are an elderly person, something like vilazodone can be given at night dose. These are the broad choices in a nutshell.
We have a question. It says, like, in your clinical practice, what is the longest duration you have seen the post-COVID psychiatric symptoms persisting, or when do they actually recover?
Okay, very interesting question. Recently I had a middle-aged lady, a 47-year-old lady, who had come to me after 13 months of recovery from COVID. I should say she had a COVID during the first phase around 13 months back, last May or so. And she was having a lot of psychological symptoms, but due to the same reason which Sunil Matthews mentioned, she was hesitant in going to a psychiatrist. She went and visited general practitioners, physicians, neurologists, ENT surgeons. She used to get a vascular headache type of a pattern, along with the low backache and all the other symptoms of depression. So she was remaining confined to the room and she was having significant somatic symptoms also. So on examination, she was really depressed. She had her menopause very recently, so she was having some vasomotor symptoms. And she had absolutely no exposure to sunlight, and on doing a vitamin D estimation, it was less than 3, obviously and understandably. So a supplementation for that, plus an SNRI, plus a low dose of benzodiazepine, she recovered. And now it is almost 1 month into treatment. She is now doing fine. She has started doing her household chores and things like that. So what we understand is that usually in a major depressive episode, 9 months is the usual duration. That is, after 9 months, a large number of people spontaneously recover, provided they haven't committed suicide in that period. That's the problem. But nowadays, in post-COVID depression, we see it being prolonged more than 9 months. Even after 9 months, the symptoms are getting prolonged if they don't receive appropriate treatment. That's the difference we see. Thank you.
Thank you. If you have any questions from the YouTube link, maybe we could tell, because we don't have anything in the chat box. Suha, sir?
No, ma'am, there are no questions, ma'am.
Okay. Joyce, ma'am,
Okay. If there are no more questions, I think we can wind up the discussion. Thank you, Dr. Arun, and all participants.
Thank you, ma'am. Thank you, sir.
Thank you very much.
Thank you, ma'am. Thank you, sir. Now moving on to the last session we have. The chairperson, I would like to invite Dr. Sukumaran, sir, to the webinar dais. He is the former HOD of the Department of Pulmonology at Government Medical College, Kottayam. He is an extremely kind and compassionate person with extensive experience and in-depth knowledge in the subject. At present, he is working as the professor and HOD, Department of Pulmonary Medicine at Pushpagiri Medical College, Tiruvalla, Kerala. Sir will now introduce the speaker for the next session and the topic to follow. I invite you, sir, to the dais. Over to you, sir.
Thank you. At the outset, I am audible?
Yes, sir.
At the outset, I would like to thank API, Central Travancore Physicians Club, and Department of General Medicine, Pushpagiri Institute of Medical Sciences, and especially Dr. Sunil and Dr. Harsha for having given me this opportunity to chair such an important session. And as we all know, as a pulmonologist, I'm sure I'm more interested in respiratory manifestations. And COVID-19 has got maximum respiratory manifestations. The portal of entry itself is the respiratory system. And even during the disease, it has got a lot of manifestations. And post-COVID also, there are a lot of respiratory manifestations which leads to mortality. So I'm extremely happy. Another important cause for happiness is my own friend, Dr. Bal Mukesh, who is actually from Trivandrum, who has done his MBBS from Trivandrum Medical College, and then MD General Medicine from and DM Pulmonary and Critical Care Medicine from the prestigious Institute of Postgraduate Institute of Medical Sciences, Chandigarh, and then he has been in the Department of Pulmonary Medicine in the prestigious Medical College, Vellore, and at present he is the professor and head of the department. He is a fellow of Royal College of Physicians, and he is a fellow of College of Chest Physicians of United States of America. And lot of, if I talk about him, because I know every details of him, and then I won't be able to tell more. But one thing I would like to especially say is he has been awarded the prestigious Srimati Kamal Sabir Award from the ICMR, and he has been trained in different universities outside India, in USA and Germany. And another important thing I would like to stress is he was the lone representative from South India in the post-COVID-19 respiratory management expert panel, which was constituted, which was actually taken up by the prestigious Vallabhbhai Patel Chest Institute, Delhi. And he has been a member of that. And I'm sure he will be the apt person to tell about the respiratory manifestations of the COVID. And over to Bal Mukesh. Thank you, Bal Mukesh. Bal Mukesh.
Am I audible?
Yes.
Okay. Is the screen visible?
Yes, screen is also visible.
Thank you very much, Sukumaran sir, for your kind words of introduction. I would like to express my thanks and gratitude to Dr. Sunil for giving me this privilege in taking part in this discussion on varied manifestation of COVID. So this is the last session, but not the least. It is an important session on COVID impacts in respiratory system. I bring greetings to all of you from Christian Medical College, Vellore. I'll be dividing my talk into mainly three aspects. One is acute COVID, the recovery period, and the post-COVID. And as I go along, I'll be trying to share our experience in managing COVID during the first and second waves. I'll just tell about examples of two patients. The first patient is a gentleman who actually presented to our emergency department with seizures. So he was found to have hyponatremia as the cause of seizures. Then he was admitted for evaluation. He didn't have any respiratory symptom, but he was, as a matter of policy, before admission, he was tested for COVID and he was instantly found to be COVID positive, although he didn't have any respiratory symptoms. And a CT scan was done for evaluation for hyponatremia. And then incidentally, it showed some ground glass opacities. He didn't receive any treatment for COVID specifically because he's asymptomatic, respiratory-wise, his saturation was normal, and he got discharged after evaluation for hyponatremia and adequate treatment of his neurological symptoms. The second patient was initially treated somewhere else. He had severe COVID, went into respiratory failure. These are his chest x-rays, initial x-rays and CT scan. And he had required oxygen support for many days. And he was discharged home from that hospital on steroids initially, and then subsequently he was started on antifibrotics, pirfenidone. And he, after discharge from the hospital, he had come to our hospital for opinion. I will tell what happened to this patient later on during my talk. Okay, so how does the respiratory symptoms progress? And as you all know, it takes around a mean of 4 to 5 days after exposure to a COVID positive patient to develop your symptoms. The incubation period, it can be up to 14 days, but the mean is around 4 to 5 days. And once you develop symptom, it is predominantly upper respiratory symptom, fever, cough, and then you'll have systemic manifestation like fatigue, anorexia, myalgia, you will have loss of taste or smell, and you have GI manifestations. And the initial few days, that many people recover, but in those with persistent symptom, they go on to develop more severe forms of the disease. After me, it is around in the second week when we start to worry whether the patient is going to worsen. In the second wave, we have seen that some people progress even much faster. Even after 2-3 days into the onset of symptoms, they progress into severe illness, but usually it is in the second week. Dyspnea happens in around 40% of symptomatic patients. Severe illness develops in 14% of symptomatic illness, and critical illness requiring organ support, non-invasive ventilation or invasive ventilation in 5% of symptomatic patients. And COVID pneumonia progressed to ARDS, acute respiratory distress syndrome. It's a major complication which can be fatal in many patients. And it occurs in 12 to 24% of hospitalized patients, and they go on to develop mechanical ventilation. In the early days of the disease, there was a lot of interest whether this COVID ARDS is different from the usual ARDS. And there are some experts, Marini and Gattinoni et al., who describe two different phenotypes, phenotype L, H, and H phenotype. The L stands for low weight and H stands for high weight. Basically, it depends on that. L means the lung is light, it is not solid. H means heavy, it is typical of ARDS. And hypoxia develops in both. In the L-type phenotype, it is due to pulmonary perfusion dysregulation. Usually, when hypoxia occurs in an affected part of the lung, there is pulmonary vasoconstriction, which diverts the blood to more oxygenated areas of the lung. But there is a dysregulation. That means that the blood keeps on flowing to the affected parts of the lung, and which causes hypoxia. And it has low, the lung has low elastance, low VQ, low recruitability, and limited PEEP response. There is other areas of the lung are not involved. So if you give PEEP, it is not of much benefit. There is also pulmonary microthrombosis. And in the H type, it is the typical ARDS like phenotype, and you have to give higher PEEP to open up the collapsed alveoli. There is high right to left shunt. There is also a lot of interest because we had started to see more barotrauma. There is pneumothorax, pneumomediastinum, subcutaneous emphysema in such patients. And some of these patients are not ventilated itself. They are not invasively or non-invasively ventilated, and spontaneously all these manifestations happen. So is it due to some kind of lung frailty which is specific for COVID? It's likely that they are lung affected by COVID. Is there is alveolar rupture, and then the air tracks into the pulmonary interstitium, and it can either come into the mediastinum and then through the mediastinum to the subcutaneous tissue, or it could rupture the visceral pleura, manifesting as pneumothorax. And there is a large study which was recently published from UK, which shows that there is increased incidence of pneumothorax, and the incidence ranges from 0.16% in those who do not require oxygen, and it gradually increases as the severity of disease goes up. And in those who are invasively ventilated, it is 6.1%, and if they have received both, the incidence is 8.5%. And they found there is no difference between the first and second waves, and there are specific risk factors other than the severity. Male sex, smoking history, chronic pulmonary disease like COPD are associated with higher risk of these manifestations. And there is no independent association with steroid use. These manifestations of barotrauma are not independently associated with steroid use. And earlier on, it was thought that COVID ARDS should be invasively ventilated, and but it was recognized because there was a thought that non-invasive ventilation is an aerosol generating procedure, and it can cause risk for the healthcare professionals. And so initially, when the pandemic started early in the first wave, we used to invasively ventilate it. But as evidences began to come, it showed that with appropriate precautions, we can manage majority of these patients non-invasively. And we in CMC started this non-invasive ventilation in our respiratory ward. We converted our respiratory ward into, which is called K ward, into a non-invasive ward. And then we used the usual BiPAP machine, which we use for COPD patients or sleep apnea patients, obesity hypoventilation patients. And with that, with some modification in the circuit, we were able to provide non-invasive ventilation for COVID patients. So what we need to understand is we have to have a BV filter, bacterial viral filter in the circuit, and the expiratory port has to, the site of the expiratory port, exhalation port, has to be beyond the filter so that the exhaled gas gets filtered and then it comes into the atmosphere. And this is very important for the safety of the healthcare worker. And we had a systematic method of prodding such patients. Initially in the first wave, we had 14 beds, and we were able to successfully manage many patients, hundreds of patients with these. But during the second wave, the number of patients hugely increased that we had to convert many of the medicine wards also into a non-invasive ward. And at the peak of the second wave, we had 150 patients receiving non-invasive ventilation in the wards, general wards, not in ICU, in the general wards. And we had to rapidly ramp up the number of BiPAP machines which are available. We had to buy, and then we had to train people, and that improved the pressure on the intensive care setup, because at one point of time there are 40 or 50 patients on the waiting list to get into intensive care, and we had to manage these patients in a general ward, and we had this non-invasive ventilation by BiPAP come to the rescue. So when to start a non-invasive ventilation, and based on multiple studies, our clinical experience, we came up with this algorithm that you can manage COVID patients who are having hypoxia with minimal supports. Like if the oxygen requirement with 2 to 5 liters, you can manage them with just a nasal cannula or a venturi mask. When the oxygen requirement increases to 5 liters or more, or the venturi, you have to give 40% venturi, then we have to see whether we have to give additional support by non-invasive ventilation. So we have to consider the oxygen requirement. We have to consider the work of breathing. Work of breathing is not exactly related to the respiratory rate. It is partly related to the respiratory rate, but it is more like the effort the patient takes to take his breath. You can clinically assess that by looking at his accessory muscles of respiration, sternocleidomastoid muscles, whether they are active, the abdominal muscles, And we have to see if these are present, or if the oxygen requirement is going beyond Venturi of 40% or nasal mask, nasal cannula of 5 liters, you have to start non-invasive ventilation. If we are, and we have developed an algorithm to manage these patients on CPAP or BiPAP. You initially start with a CPAP of 6 centimeters of water and gradually increase it. We start with 15 liters of oxygen and rapidly try to bring the oxygen flow below to maintain a safe oxygen target, to maintain an oxygen saturation of more than 90%. And then we see the patient, we see the work of breathing, and then if the patient is still tachypneic, if the saturation more than 90% is not reached, we increase the CPAP by looking at, but also giving careful attention to the subcutaneous emphysema. You palpate the neck and the chest just to make sure that you don't inadvertently precipitate a barotrauma. And then at 30 to 60 minutes, you do an ABG. And based on the ABG, you see whether the patient has achieved your target saturation and comfortable breathing, then you continue the same. If the patient is still hypoxic and it has increased work of breathing, carefully you can add IPAP to the BiPAP machine. But you have to understand that adding an IPAP to that machine can actually decrease the delivered FaO2, because here the FaO2, actual delivered FaO2, we don't have a control over it. It is a mixture of how much oxygen flow he is giving, the patient's inspiratory effort, the mixture of oxygen as well as the air which is being delivered by the BiPAP. So all these causes a decrease in FaO2 if you keep on increasing the IPAP. So we have to be careful about that. And you look at the many of the BiPAP machines have measurement of the tidal volume, delivered tidal volume. So you have to keep a watch on it, because if you deliver excess tidal volume, you can cause barotrauma. So you have to keep on the tidal volume, and there are some ranges of tidal volume depending on the L type or H type phenotype, which cannot be, we cannot be sure about it, but you have to have a general idea, because we have seen people on low pressures, patients have generated tidal volume more than 1 liter, and some people have gone to develop barotrauma. So we have to be careful about that. If the target saturation is achieved, but patient is struggling, he has increased work of breathing, then you have to give adequate sedation or anxiolytics, because increased respiratory effort can itself cause what is called patient self-inflicted lung injury. So you have to make sure that patient has adequate comfort. And most important thing is you have to have a 24-hour people to manage this. You have to have continuous oxygen saturation monitoring, people who can adequately manage if the patient deteriorates suddenly or he develops an arrest. You have to have a adequate monitoring facility to manage such patients. And this is our experience from the first wave. In the first wave, we had 272 admissions in the general respiratory ward, which was converted into a non-invasive ward. And among that, 80.5% people were successively able to wean off, and they were shifted out to the ward. So the success rate was 80.5. 7.5% they were had to be shifted to a medical ICU because they continued to deteriorate, and 12.1% of them died. And in many of them who died, it was decided based on discussion with the family that NIV is the ceiling of care. He is not good for, it's not appropriate to go for invasive ventilation. Dr. Joseph John has nicely talked about the thromboembolic complications. I won't be dealing with that. And we need to about our first talk was on the COVID-associated mucormycosis. But not only mucormycosis, we need to aware about other infections as well. In a study from North India, this is again the first wave from 10 hospitals, COVID hospitals. They found out that the incidence of secondary bacterial or fungal infections were 3.6%. So it's not much at least during the first wave. But in those who developed secondary infection, the mortality was 56.7% against an overall mortality of 10.6%. So this is general trend that the infections were rare, but if they develop infection, the mortality was high. This is a meta-analysis of many studies, again, during the first wave. The co-infection rates, co-infection with bacterial rate at admission was 3.5%. And secondary infection, but that means that they had admitted with COVID during hospital stay, they develop a secondary infection, then a secondary infection rate of 15.3%. But the antibiotic prescription was nearly 72%. So there is a lot of overprescribing of antibiotics, which can potentially be harmful, because if they develop a secondary infection on top of an existing antibiotic prescription, it is likely to be a drug-resistant pathogen, and where the outcome is very bad. We talked the first talk with Dr. Mary. She nicely talked about the COVID-associated mucormycosis, but not only other fungal infections were also associated with COVID. In one literature review, up to 1/3 of patients had developed pulmonary aspergillosis, and the mortality again, if they developed, was high. So we talked about COVID, acute COVID, and then the COVID-associated complications, and then come to the COVID recovery period. And it's been known that patients with COVID, even after recovery, discharge from the hospital, they persist to have symptoms. Up to 1/3 have persistent symptoms, and some of them have a new or worsening symptom. And studies from abroad have shown that most of the symptoms are related to respiratory symptoms, dyspnea, shortness of breath, and cough. We in CMC had a post-COVID clinic. We call it a post-SARI clinic. And this is the data analyzed after the first wave. When we analyzed our cases, the most predominant symptom in those who come to our clinic was dyspnea. More than half of our patients had dyspnea, and cough was present in 1/4 of the patients. And earlier on, during the first wave, we were worried about pulmonary fibrosis secondary to COVID-19. It is justified to worry about it because the sheer number of individuals affected by COVID-19. We don't worry about fibrosis, pulmonary fibrosis secondary to an infection by influenza or pneumonia, or not even tuberculosis. We didn't worry about fibrosis, but because of the sheer number of patients admitted with COVID, we were concerned about pulmonary fibrosis or secondary to COVID, otherwise called post-COVID ILD, interstitial lung disease. Dr. Zarir Woodwadian had a nice review article in Lung India, in which he termed the tsunami that will follow the earthquake, the tsunami that will follow the earthquake. And this is after the first wave. Now, after the second wave, in which multiple times more number of patients were affected, we need to be geared to face this tsunami that we may come in the next few weeks or months. So what happens actually? So any insult to the lung, fibrosis is part of the healing process. But we are worried if there is excess fibrosis, which is more harmful than doing good. There is some pathogenetic mechanisms that there can be overexpression of fibrogenic cytokines in a subset of patients, which can lead to fibrosis. And also SARS-CoV-2 infection virus per se can downregulate the ACE2 receptor, and which can cause myofibroblast activation and extracellular matrix accumulation, which can potentially lead to fibrosis. And this can be further complicated by oxygen therapy. Hyperoxia can cause increase in fibrosis, as well as ventilator-associated lung injury can also aggravate the lung fibrosis. So there is justification that pathogenetically there is potential for fibrosis post-COVID. Is it specific for COVID? This is one study after ARDS. This is the pre-COVID era, in which even after severe ARDS, pulmonary abnormalities were detected in 3/4 of the patients up to 5 years after the recovery. And ground glass opacification and fibrosis were seen in nearly half of them. But what is interesting is, just because there is presence of some abnormalities on the CT scan at 5 years, it was not significantly correlated with the reported respiratory symptom, pulmonary function, days of mechanical ventilation, or the quality of life. As you can see, at 5 years and 1 year and 5 years after severe ARDS, pre-COVID, there is almost near normalization of pulmonary function test, FEC, TLC, but DLCO was mildly reduced, 77 and 73%. The authors say that the exercise and functional limitations surveyed by survivors of severe ARDS is unlikely to be related to the structural lung disease and may be more consistent with extrapulmonary muscle weakness. So not only the lung per se can contribute to symptoms, it is the muscles, the respiratory muscles, or the deconditioning can also be cause for the dyspnea. What about other corona, the SARS-1? We have a couple of studies which looked at long-term outcome of the SARS-CoV-1 infection. This study, which looked at 1 year follow-up, in which we showed that 1/4 of them had diffusion capacity limitation, and 1/5 of them had persistent fibrotic changes. And as time progresses, at 2 months, the diffusion capacity was nearly 60–70%. At 11 months, it improves to 79%. So there is a tendency that it will improve. Similarly, for vital capacity, it was 87% at 2 months, and it improved to 103 at 11 months. This study looked at 15-year follow-up after SARS-1 infection, which happened in 2003. And it showed that the lung function improved from the initial 1 year and remained stable for almost next 14 years. So there is a tendency for improvement which happens mostly in the initial few years, and thereafter it remains stable. There is no signal that it will set off progressive fibrosis and then they are going to have disability because of the loss of lung function. It doesn't look like that. In our experience, this is after the first wave. In our post-SARI clinic, we didn't do serial CT scan because that's not part of our protocol to do serial CT scan, but we did chest X-ray, and we compared during 2 standard scoring systems called RAIL score and Yasin score. RAIL score is against a total score of 48, and Yasin score is against a total score of 8. And you can see in all the categories, this baseline means at COVID, when during acute COVID, and this is at follow-up at 6 weeks. In all the categories, their score significantly has come down in all the categories. So at 6 weeks, a significant majority of the people has improvement in their chest X-ray findings. And we also found that in lung function, we didn't do baseline lung function because you can't do it when the patient has acute COVID. At a mean of 9 weeks, in all the categories, there is mildly reduced vital capacity as the severity of the illness increases, there is greater reduction in the vital capacity. Similarly, it applies for total lung capacity, diffusion capacity as well. Even in the 6-minute walk distance, as the severity of the illness increases, there is greater reduction in the lung capacity. And there is restriction is found in 73%, obstruction in a minority, and impaired diffusion in 58%. So after recovery from the COVID, a significant number of patients have lung function impairment. This is a study from Wuhan, which looked at serial CT scans at discharge, first week, second week, and third week. And what it's interesting to find it, majority of the findings show a improving trend. Ground glass, even the fibrous stripe, which is predominant at discharge, continue to improve till third week. This is another study which again looked at that in 2/3 of the patients, the lung lesions were fully absorbed at 4 weeks follow-up. This is even the supposedly fibrotic changes like interlobular septal thickening. At 2 weeks, the incidence decreased from 80% to 49%, and at 4 weeks, only 35% had interlobular septal thickening. So even the supposedly fibrotic changes continue to improve over a period of time. There is another study which looked at 6 months follow-up of COVID, 41.5% had pulmonary dysfunction at 6 months, and the residual lung lesions were more common in the severe group. Another 6 months follow-up study, fibrotic-like changes were present in 1/3 of the patients, and 1/3 of them, there is complete radiological resolution. When they looked at risk factors for fibrotic-like changes, age more than 50 years, heart rate more than 100 beats during acute COVID, duration of hospital stay more than 17 days, ARDS, and initial CT score of 18 or more were independently associated with fibrotic-like changes at 6 months. They like to call it as fibrotic-like changes because they were not sure whether these changes will persist or resolve with time. Dr. Atul Wells, who is a world-renowned expert in interstitial lung disease, in his article says that most of the post-severe acute respiratory syndrome CT findings considered to denote fibrosis at the initial CT follow-up continue to regress in the long term. And there are two likely pathogenic pathways in severe COVID. One is the diffuse alveolar damage because of the viral infection or ventilator-associated lung injury, healing by fibrosis. Or the other pathway is, which we don't know for sure, is probably there is an auto-inflammatory pathway contributing to vascular lesions, organizing pneumonia, which subsequently lead to fibrosis. So much is needed to know what exactly is the pathogenic pathways which subsequently leads to fibrosis. This is one protocol for how to follow these patients. This was published in Thorax. In mild to moderate pneumonia, they say that you follow by a chest X-ray at 12 weeks. And in patients cared for who are critically ill, you follow them up in 4 to 6 weeks and subsequently at 12 weeks. I will come to what we usually follow. So how do you manage a patient who comes with post-COVID pulmonary sequelae, or we can call it post-pulmonary, post-COVID ILD or post-COVID fibrosis? Most important is it is supportive treatment. We need to treat the patient, his symptoms. If we need to see whether the patient is hypoxic, if they are candidate for long-term oxygen therapy, we need to give them. pulmonary rehabilitation plays a very important role. We need to advise them from vaccinations, a COVID vaccine after 3 months, or other vaccines, influenza or pneumococcal vaccine, because the lung is already been affected. We don't want any further insult to the damaged lungs. What about medical treatments? What about steroids? Steroids, again, we had multiple discussions earlier today. Excess use of steroids is harmful. It can predispose to mucormycosis. It can predispose to other infections, bacterial or aspergillus infection. So beyond the acute setting, there is no definite reason that you continue to give high dose steroids. There may be a subset of patients in which you may consider low dose steroids, but that is not standard of care. You have to weigh the risk benefits. As a standard practice, don't give steroids beyond the acute COVID situation. What about antifibrotics? I will come to that. What is of proven benefits, which beyond doubt should be given to all such patients, is pulmonary rehabilitation, which has been shown by this study from France. These patients were admitted in ICU with the severe COVID, and they gave intense early pulmonary rehabilitation, and they did weekly 6-minute walk test. And as you can see, all of them who have been given pulmonary rehabilitation improved in their walk distance, and the slope of the curve is more in those in which rehab was started earlier, and it flattens out when the rehab was started late. So a patient in hospital, you have to start rehabilitation when he is just able to do some sort of exercise, and you have to start it early enough to have the maximum benefit. And this has been proven to improve the overall outcome in post-COVID sequelae. There are 3 types of sequelae, and this has been beautifully explained by Dr. Udvadia in his article. The most common is majority of these patients improve on follow-up. Even the post-COVID fibrosis patients improve. A less common phenotype is they remain static. They have a static fibrosis and they remain the same. There is nothing much we need to do for these two. Only rehab is the treatment which you need to give. There may be a subset who have progressive fibrosis. Their undiagnosed viral infection is one of the causative agents for idiopathic pulmonary fibrosis. So maybe there is a subset which we are not sure yet, which go on to develop progressive fibrosis, and probably there is a potential role for this group, but we do not know yet whether this is a how common is this, whether there is any proven role. But we have to do definite follow-up of such patients to detect these patients who have progressive fibrosis, and there may be a potential role to intervene in this group. Nintedanib, it has been found to be useful in progressive fibrosing interstitial lung disease. How it helps? It helps to decrease the decline in the lung function. So it doesn't improve, it helps to decrease the decline. So if without in the placebo group, it declines like this, it slows the decline. So only if COVID has been found to cause progressive pulmonary fibrosis in your patient, you need to go on to give nintedanib. And that group is, we do not know whether it exists, and even if it exists, it's in a minority. So what we need to do is close follow-up. And same for pirfenidone. What pirfenidone does is not to improve the lung function, it prevents the decline in vital capacity. So what we do in our clinic is at 4 to 6 weeks, we call back the patients who have been discharged after COVID in the hospital. We do a chest X-ray, and we do a lung function test and a 6-minute walk test. If the patient's chest X-ray is satisfactory, lung function is satisfactory, does not have much desaturation, then we give pulmonary rehabilitation. But if the patient is significantly symptomatic or there is significant desaturation, we consider doing an echocardiogram to find out whether the patient has pulmonary hypertension, or we do a CT pulmonary angiogram at 4 to 6 weeks if the patient has significant desaturation at that. And then we discuss in our ILD MDT, multidisciplinary team meeting. If the patient has been stable at 4 to 6 weeks, we again follow them up at 3 months. Again, we repeat a chest X-ray and PFT. If the PFT is stable and or improved, we just keep them under follow-up. So if there is deterioration between 6 weeks and at 3 months, then we do a CT pulmonary angiogram, and then we discuss in interstitial lung disease. If there is deterioration, which we have not seen many patients who have deterioration in their lung function between 6 weeks and 12 weeks, then potentially there is a role to intervene at that point. And there are a lot of ongoing trials which looks at these antifibrotics. So we'll have more data whether what is the potential role for antifibrotics. As of now, it is just speculative, and we should not be using it as a matter of routine. Coming to the patients which I discussed at the initially during my talk, this patient who had ground glass opacities on CT scan, nothing was given for him, no specific treatment, it completely resolved on follow-up. The other patient who was being given steroids, antifibrotics from another hospital, we repeated our scan. It shows that it was stable or fibrosis or improved fibrotics. His lung function is impaired, but there is a borderline bronchodilated reversibility. What we did was to stop his antifibrotics, started him on inhalers in view of his bronchodilated reversibility, and he was given intense pulmonary rehabilitation. So in conclusion, there is significant post-COVID sequelae, especially in those with ARDS and severe illness. It causes significant morbidity. What is required as of now is close follow-up to make sure that they don't have any progressive deterioration in lung function, give pulmonary rehabilitation, which has been proven to have a definite role. Thank you for your kind listening.
Thank you, Dr. Mukesh, for the excellent narration of COVID manifestations and post-COVID manifestations and during the period. And I'm sure there will be some questions. Any questions first, yes, or comments? Then I will tell.
Yes, we have a few questions. Sir, may I start, sir?
Yes, yes.
From Dr. Achyutan, what is your expert opinion regarding nebulization in COVID patients? That's the first question.
Okay, nebulization. I suppose the question is if you want to give a bronchodilator for a COVID patient. So earlier on, the concern was of giving nebulization was it's an aerosol generating procedure and there is risk for healthcare workers. So as a standard of practice, we don't give nebulization if required for COVID patient. What we give is meter dose inhaler with a spacer, and even with a BiPAP NIV circuit, there is a connection in which you can attach a meter dose inhaler and give them puffs. But having said that, there is some recent expert opinion that nebulizer is not as harmful as we earlier thought. The aerosol particles which goes away into the atmosphere is mainly the medicine which goes out and not the patient exhaled particles. So they say that is not proven by any study, but it is the explanation is what it comes out is what the medicine and not the particles which are deposited for the lung. But as a standard practice, it's good that you use meter dose inhaler. But if you are no choice, patient is not able to take MDI, you can use nebulization.
Okay, thank you. Sir, the next question is, how do we differentiate severe COVID pneumonia and cytokine storm when they're present? And does the management and sequelae differ in both?
The severe COVID pneumonia is according to the WHO definition. If the saturation, room air saturation is less than 90%, that qualifies for a severe pneumonia. How to identify cytokine storm? It's a difficult. You have to use your clinical situation, how the patient is deterioration. Usually, such patient has an acute deterioration in a matter of hours to 1 or 2 days, and then it can be corroborated by increasing oxygen requirement, new onset of shadows in the chest X-ray, and blood parameters like CRP.
Sure, sir. Thank you. And so the other question we have is, do we find an increase in sputum positive TB following the COVID-19 pandemic? Is there an increase in the incidence?
Sukumaran sir, you can.
Not very sure. I am also not sure, because the only thing which we in Kerala was actually we had a decrease in number of cases, because maybe they were not taking proper this thing. So we had in almost all post-COVID clinics, we insist that sputum should be examined in general hospital, because the number of cases detected in the last 1 year, it was very less when compared to the year before. Because the active TB finding was not done very much, because there was a backdrop in that. So now all post-COVID clinics in government hospitals and in private hospitals in Kerala, we have asked them to routinely examine, but we have not got any data now. I don't have any idea. But active case finding should be done in cases.
Okay.
Hello, Mukesh sir. I want to have one question. In patients with COVID pneumonia, what is the indication of starting the patient on antibiotics? And what is the criteria which you have to tell that the patient has got a secondary infection?
And that's a very important day-to-day issue, when to start the patient on antibiotics. When a patient presents to hospital in the emergency department with a febrile illness, it's a standard practice that, okay, X-ray shows a shadow, you start on antibiotics. But as soon as you get the COVID report, if the COVID report shows that it is positive, then you have to stop the antibiotics which has been started in the emergency department or he has been taking earlier. Because majority of the patients do not require any other antibiotics. It will complicate the issue later on during the illness. And the patient recovers well with minimal oxygen requirement, you need not worry about antibiotic at all. But the antibiotics need to be taught in 2 situations. One is the patient had a secondary deterioration in his clinical status. He was stable for a few days, his oxygen requirement suddenly started worsening. It can be due to 2 reasons. It can be due to cytokine storm, or it could be due to a secondary bacterial infection. The second situation in which we need to worry about secondary infection is when the patient has impaired swallowing, either because of you have put rice tube on an non-invasive ventilation mask, or you have intubated the patient, he becomes high risk for a nosocomial pneumonia. In such situation, again, you should suspect secondary infection. And it is sometimes very difficult to differentiate based on only clinical or chest X-ray features, whether you are treating, dealing with a COVID worsening or a bacterial pneumonia, because neutrophil count can go up in both cytokine storm as well as bacterial pneumonia. What about CRP? CRP increases in both. Procalcitonin can also increase in, although it is more specific for bacteria, but studies have shown that it can go up even in severe COVID pneumonia. So we have to rely on blood cultures. So what we need to do, if a patient deteriorates, we have to start on antibiotics, but send all cultures. If expectoration is there, start them on, send blood cultures, urine cultures. And if the cultures are negative, and there is no significant responds to the antibiotics, better not to continue it, you stop the antibiotics. So it is a difficult decision when you are dealing with a deteriorating patient.
Dr. Balabhagesh, thank you very much for that presentation. It was very nice. I would just like to ask you, how do you de-escalate your oxygen, just like how you go upwards? When do you start? What are the parameters? Are they clinical? Are they just looking at the saturations that we come down? Because we know we have to maintain up to 92 in COPD patients and otherwise. So what are your parameters and how do you de-escalate? Because just like how we escalate, we have to de-escalate also slowly, right?
Yes. Yeah. So do you mean when a patient is on NIV or just oxygen?
NIV coming.
Okay. Yeah. So the usual protocol which we follow is the initial, as soon as the patient is started on a NIV, the initial 24 hours we give almost continuous NIV. After 24 hours, if the patient has stabilized, then we start giving breaks. We start giving initially food breaks or fluid breaks. We allow him to take some fluids orally, intermittently for a few minutes. And then he is tolerating the fluids, he is able to swallow. We start giving food breaks as well. The next day, we start giving 1:3. That means 1 hour break followed by 3 hours of NIV. The next day becomes 2:2. The following day, it becomes 3:1. And the following day, that means that 3 days from that time, from the initial when we started weaning, we try to, if he progressively improves, he is completely off NIV and then we manage. So this is the rough protocol which we follow, but it varies from patient to patient. How fast we are able to wean definitely depends on his oxygen status. Also, rather than decreasing the pressures, we give breaks. We don't come down on the pressure. We start giving breaks, and that's how we manage the patient. And during the breaks, we put the patient on either Venturi mask, or if he is taking food, we put him on nasal prongs.
And what is this pulmonary rehabilitation? When do you start it? I mean, when do you start it? With what time course of the patients?
Yeah. So we have our, even on our general wards and in the COVID wards in the general, we have our physiotherapists coming. Even for patients who are on minimal oxygen, they are being mobilized. They are taught some breathing exercises, mobilization exercises. And we have like a pamphlet which was modified from a WHO document, which can be given to patients on discharge, because when the patients are discharged home, they go to they are advised home isolation. So they go home, they are stuck inside their room, not able to move, do anything, and that worsens their disability and deconditioning. So we encourage them to do exercises even at their room. So there is a booklet which you can share, or it's if you can serve WHO pulmonary rehabilitation after COVID, there is a document which describes beautifully with diagrams what they can do even at home. Limb exercises, breathing exercises, and that is encouraged. And then we call them to our post-SARI clinic at 4 to 6 weeks, where they are formally assessed again by a physiotherapist, and then give appropriate rehabilitation advice.
Thank you. Thank
you. Dr. Balmukesh, do you think when you're following up at 6 weeks, suppose you think the patient is slightly progressive fibrosis, is there any role for steroids? Because I said peptidone, I agree, but shall I, and budesonide, because almost all patients are on budesonide. How long we should give, and whether oral steroids are to be 6 weeks? I am doubtful. Yes, I think it is not, it is progressive. So steroids, whether they will be useful or not?
Yeah. So that's a very important question, which I am not able to give a straightforward answer. So inhaled steroids, there is not much harm in giving on a long term, because we have been giving for asthma, COPD, but the dose of steroids is little high. So we need to be careful that they take proper spacer, gargle their mouth, otherwise they will develop oral candidiasis. Regarding systemic steroids, according to the most of the trials, what they have given is 10 days and stop. But we don't know whether giving more may be required for some patients. So in a subset of patients, there may be a role in not abruptly stopping, but a slow taper over next couple of weeks. Maybe there is a role. We also do it in some patients, not routinely, but we have to again look at are they diabetic? Are their blood sugars under control? Because we don't want to cause a harm by continuing steroids for a long period of time.
Another question is, because do you have any patient on nintedanib or pirfenidone now on post-COVID? Because nintedanib, actually it was very costly. We were not using it at all. Once the COVID came, it was almost 8,000, very, very less. At most it becomes 20%. So everybody has started using it, and I see a lot of prescriptions for in the early period. As you have rightly said, it need not be given. But do you have any patient on nintedanib now or pirfenidone now? Now it is more than 3 months. You must be having a lot of patients.
If I remember, hardly 1 or 2 patients only we decided to either start or continue one of the antifibrotics. In majority of them, we found that this fibrosis is not progressing. And so we didn't feel the need to start them on that.
And another thing I would like to ask is whether you do CD diffusion, because as you said, if you do one diffusion, because it has got a wide range of normalcy, how will you assess? Because it's a little difficult. And you also said it is not only the lung which contributes to the 6-minute walk test. So how do you don't do HRCT also?
No, we don't do serial HRCT. Even during acute COVID, majority of them, we don't do CT scan. What we do is a chest X-ray and a lung function test, in which we do also diffusion capacity, so that we get an overall picture, and we do a 6-minute walk test.
Thank you very much. Any other questions? Any other comments?
Yes, sir. There are 4 more questions in the YouTube.
Okay, sorry.
Can I take it, Dr. Harsha?
Oh, yes.
Or after that?
Oh, no, what do you say, Harsha? I'm sorry. Harsha?
Yeah, so
no, it's only one. There is up to 1 we have time, no? Another 5 minutes is there. No, questions can be answered. This is important. You ask fast.
So there are 2 questions on the role of pesticides and in COVID recovery. 2 questions are regarding that, and the other one is regarding monoclonal antibodies. So I think we have covered all the questions by those 3.
Yeah, N-acetylcysteine, initially it was even used in ILD UIP pattern, but it was not found to be useful. It has some antioxidant effect, which can potentially be helpful, but again, it has not been proven to be useful. So there is no role for routine use of N-acetylcysteine. Second question is antibody for acute COVID, is it?
No, sir. They generally asked regarding treatment in COVID. How effective are the monoclonal antibodies?
Yeah, monoclonal antibodies has been it's been made available recently in India. It's been found to be useful in people who are not yet hospitalized, like in the mild or moderate COVID, who have high risk of progression. They are elderly, they have comorbidities. It has been found to have some beneficial effect in preventing deterioration, but it is costly. As of now, it is around 60,000 per dose.
Yes, thank you, sir. I think we've come to the end.
So in the YouTube, there are 4 more questions. The use of beta agonist in PTS with COVID and asthma, and is any role of monitoring extravascular lung water index?
The first question is?
First question is, sir, use of beta 2 agonist in PTS with COVID and asthma.
If the patient has bronchospasm, you have to use one of the beta 2 agonists like salbutamol. Especially in acute scenario, you need to use them. If they are stable asthma, you have to use what they have been taking earlier. It may be a long-acting beta 2 agonist, which they are, along with inhaled steroids, which have been already taking. And if it is an asthmatic who developed mild COVID, better that you give the inhaled steroids dose has to be increased. The budesonide has to be 800 microgram twice daily. So we'll have to give additional steroid inhaler in addition to the ICS LABA he has been taking. Regarding measurement of extra vascular lung volume, it is not a very easy method to, there is some methods in invasively ventilated patients, but I'm not sure whether you can base your treatment. I'm not an expert in that, so I would not like to make any comment on that.
Okay, sir. Sir, one more question. Wave 3 is correct information. How virus is adding his complications with respect to age? First wave above 45, second wave below 35, and third wave on children. Is it a correct information?
Sukumaran sir, what do you think?
I hope it does not come. That's the only thing. I pray that third wave doesn't come and affect our children. If it is true. I don't know. Any idea? Okay. Anybody else? Mary John is there. Mary John, Vijay Kumar.
I hope we all get vaccinated and don't pass it on to the children.
So that's also, I pray that there is no third wave, at least in India. I don't have in the old world. Okay, if it is over.
Yeah. One more last question is there. When to interfere in elderly post-COVID patient with mild respiratory systems, and any investigation will suggest referral. When to interfere in elderly post-patient COVID patients with mild respiratory systems, and any investigation will suggest a referral apart from a low SpO2.
Is it during acute COVID or post-COVID? What did they say?
They are not mentioned, sir. They are just
Okay.
mentioned COVID patients with mild respiratory systems.
Okay. So mild respiratory symptom, elderly, normal saturation, whether there are any indicators of intervention or hospitalization. That's a very important question. I would say that persistent fever for more than 7 days, you start to worry about. So most of the fever should subside in 7 days. If it is persisting beyond 7 days, or his cough is becoming more severe beyond 7 days, you start to worry about whether he needs hospitalization. Other thing, even if room air saturation at rest is normal, if he is on walking, there are like if you cannot, they may not be able to walk for 6 minutes, but even 40 steps, if they can walk, and if their saturation drops by 3% or more, that suggests that he is likely to progress, and he may require more intense monitoring by admitting him to hospitalization. So these are the things which you can do if the patient, you are elderly and they have persistent symptoms.
Okay.
Okay, then thank you, Dr. Balmukesh, for the excellent talk and very clear answers. I'm extremely thankful to Professor Balmukesh. Thank you very much, Balmukesh, and thank you the organizers for giving me the opportunity. We both thank you all. Thank you.
Thank you very much.
Thank you.
Thank you, Balamukesh sir and Sukumaran sir. Sir, I would like to invite Dr. Mary ma'am to have a short talk on the overview over the presentation of COVID in her institution, and basically about the management that they are doing in the current scenario. Ma'am, over to you, ma'am.
Actually, yeah, thanks. I'll just make it very short. So basically, when a patient presents with COVID-like symptoms, they are triaged in our COVID casualty emergency, and we just take the history. Any fever with respiratory infection as of now, fever with cough or breathlessness. So they are triaged there, and the saturation is quickly checked. If they're more than 95% saturating, we usually just quickly do an X-ray chest and ask them whether most of them would just like their tests to be done, and they're sent back. If it's between 90 to 95%, we and they have risk factors, 94%. They have risk factors. We advise admission. And once we admit the patient, then we just follow the usual, I'll tell you what we do. And if it's less than 90, straight away the patient is admitted into the COVID ICU. And so once admitted, after doing the test, the TrueNat or the RT-PCR, which we don't do the antigen test, the RT-PCR or the TrueNat, which we do, the patient is then looked after. These are moderate cases. If it's below 94 and above 92, 90 to 92, we call it moderate. So we keep this patient on oxygen therapy. We start off dexamethasone, and we see whether the patient has come within the first week of illness. If the patient is, he's definitely hypoxic. So in the moderate cases, we start them on remdesivir. Once we get the blood reports, once the creatinine values, the EGFR is more than 30, and he has no rise in OTPT, so we give them remdesivir. And and we continue to monitor this patient's oxygen levels and send off their other lab parameters like CRP and D-dimer ferritin levels, CBC, blood urea creatinine, the basic investigations. And these patients are monitored, and if at all they need escalation of therapy or they worsen, then they are taken into the COVID, the level 3 care, where they are put into the ICU. And the patients who have already a low saturation presentation, they are immediately put on oxygen. And in the meantime, their tests are taken. And again, we have to see whether they've come within the first week. Then we do give a trial of remdesivir to them. We do give them remdesivir. And sometimes patients present in the second week, they're diabetic, and they present in the cytokine storm. So we have given patients after consultation and sitting together, we had given them tocilizumab also. We send CRP. CRP is an indirect indicator. We don't send IL-6. It's expensive and not freely available as a test. So we look at the CRP levels. If it's more than 75, then we have been using tocilizumab on these patients. And these patients are then continuously monitored for their oxygen levels. We keep escalating or de-escalating according to their condition. And finally, most of them go home, but the very sick ones, we have not been able to salvage quite a few of them. We have intubated some patients, but we had a very poor extubation rate. We haven't had too many patients coming off the ventilator. So that is our story here. It's just a very quick way of how we have been managing patients.
Thank you so much, ma'am. Any of the panelists would like to add anything? Now is the time. I would request anybody to add further to the discussion we just had.
Madam, remdesivir usually it is out from the list actually, but we are still continuing the remdesivir.
Yeah. Somehow I found it in the first week of illness. They're coming still with high fever persistence, because that's a viral phase, right? That's up. If you know definitely when the patient started his illness, because beyond that it doesn't have any role. It's like an antiviral. Yeah, that's it. Even though it's gone off the list, we are still using it. Yeah.
Thank you, ma'am. As we have come to the end of the 5 sessions, I'm sure we all had an informative 5 different talks and a fruitful discussion. It's imperative that I thank all the eminent speakers and the renowned chairpersons who helped us have an informative session and a fruitful discussion. So on behalf of all the organizing committee, that is Pushpagiri Medical College General Medicine Department, the Central Travancore Christians Club, and the Kerala chapter of API, I would like to extend a sincere gratitude to all the renowned speakers and our chairpersons to have given us valuable information and guidance in this current scenario. I would also like to thank our coordinator, Dr. Sunil sir, who has been the backbone of this particular seminar, without whom it could not have been possible. And I thank him specifically for his constant support and guidance. A big thanks to the organizing committee and the team of Microlabs for their constant cooperation. And last but not the least, I would like to thank the audience who have actively participated and have given so many inputs to this discussion as well. Thank you so much. Have a good day. Thank you.
Thank you, ma'am. Thank you, Dr. Harsha and Dr. Sunil, sir. Thank you very much, sir. So for giving us opportunity to give the platform. So we look forward for some more sessions on this interesting topic, sir. Thank you. Thank you so much, sir.
Thank you,
madam. Thank you very much.
Thank you. Thank you very much.
Thank you, Dr. Sunil, sir. It was wonderful as usual. Very nice, very enriching. I'm sure all the participants, definitely it will make an impact in the practice. Wonderful, sir. Thank you so much for giving us an opportunity. Thank you, ma'am, Harsha, ma'am. Thank you,
sir.
Dr.
Thank you once
Sukumaran,
again.
sir, Dr. Vijay Kumar, sir, everyone, and Dr. Uni Krishnan.
Thank you.
Thank you, sir. Thank you once again from
Thank you, Dr. Sunil
Microlabs.
Kumar and team, Harish
Yeah.
Kumar, sir. All meet.
Everyone. It was really wonderful.
Fantastic. Thank you very much, sir.
Thank you, ma'am. Thank you, ma'am.
So
So
looking
I will
forward
end.
to the next one, sir. Matthew, sir. Next one.
No COVID. COVID is exhausted.
Next one it should be with physical meeting.
Yeah, definitely, sir. We will have one.
No, we will have food together because
Certainly, sir. We will have one physical CME very soon, sir.
we will have food together. That's
Yeah. We are looking forward
very
to
good
that,
food
sir.
for thought, but food for stuff is necessary.
Yeah, we are looking forward to that, sir. Certainly. Thank you very much.
Okay, sir. Bye.
Hi, Sumar, sir.
Yeah, Mr. Unni. Yeah, we will have soon. We'll have physical CME as well as
Physical
possible.
meetings. Okay.
Yeah.
And sir,
Okay.
otherwise also Kottayam, IMA and IAP, we are planning together one, sir.
Okay,
Sumar, sir called me. So we
Sure. Okay.
Bye.
Right. Thank you, Sunil
Bye,
Matthew.
bye.
Thank you very much. Bye.
Bye, sir.
Thank you, ma'am. Bye.
Bye, Mr. Unni. Madam, thank you.
Yes, sir.
Thank you, sir. Bye, Mr. Unni.
Bye.
Bye, Suhas. Bye,
Bye,
sir.
Bye, ma'am. Bye, ma'am. I will end the session, ma'am, now.
Yeah.